हेलो 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 हेलो
Hello, Dr. Meghnad.
Sir, good afternoon.
Good afternoon, Dr. Meghnad. We are connected. I can see you on the screen, and the voice is also clear.
Thank you,
Um,
sir.
so morning sessions were good. We had cochlear implant surgery by Dr. Raidu, then two cases by Satish Jain from Jaipur. Then we had a couple of good talks on cochlear implant and mastoid. So now we just had lunch, and
Good, sir.
so 2:30 was the time that we were connecting. So I think
Fine.
everybody is coming from lunch, and we start in 10 minutes.
Yeah.
Perfect, sir. Perfect.
How much time we have?
So uh, you will take us through. So 1 hour, 1 hour plus, or 1.5, whichever you want.
Yeah, 1 hour. 1 hour is good enough.
1 hour is good enough. Okay. So 2:30 to 3:30 is for you.
Yeah.
Yeah.
Fine. Thank you.
Yeah. Okay, sir.
Thank you. Welcome. Hmm. ఉన్నది ఆపచ్చు కదా మనం ఆడియో ఎలాగా కానీ ఇప్పుడు వాళ్ళ వాయిస్ కూడా కట్ అయిపోతుంది.
कनेक्ट कर दो. वो 26 तो हो गया. Hello. Yes, Dr. Meghnad. Can you hear me? Dr. Meghnad?
हेलो हेलो
Dr. Meghnad, can you hear us?
Yes, we can hear you. Comfortable?
Yeah, so everything is set.
Everything is yeah.
Dr. K.R. Meghnad is, everybody knows him, so there's nothing to introduce him. My ENT hospital, a wonderful hospital which I have visited twice or thrice, I think, in the last 20 years. And wonderful workshops almost 2 or 3 times a year. And wonderful prolific surgeon, sinus surgeon as well as otologist. And I request him to give this talk on functional endoscopic sinus surgery. Sir, please.
So the plan is to have some basic lectures on the uncinectomy, and then we'll go for the. Am I audible?
Yeah, you are audible a little bit. We are increasing the volume here. Yes, sir, we can hear you.
Yeah. Yeah, first I'm starting with share. AC बढ़ाओ भैया. No, not that one. This is the one. So basically, we have to do a good surgery for the maxillary sinus, which is a very important in giving the relief to the patient. So we have to do the uncinectomy, a very good uncinectomy, middle metal antrostomy, and what I emphasize is a complete uncinectomy alone will give relief to the frontal sinus also in good number of cases. And we have to remove the irreversible pathology and retain the reversible pathology so that it will revert back into functioning mucosa. So that is the fundamental concept of the functional endoscopic sinus surgery. So what is the best way to do the uncinectomy? This is a very important point here. There are different techniques of uncinectomy, and let us go with each one. One is the sickle knife. We were very well taught in 1985-90s. Then we started using the free salvator in certain indications and the backbiter, which is very much populated by my guru in sinus surgery, Professor Dharambir Sethi from Singapore. And of course, when The other way is using a ball probe. We'll look into those things. The most important point here is when you are using the sickle knife, it has to be parallel to the lateral wall of the nose. The tip never, it should be directed laterally, and if so, it may enter the lamina pepraea. And some sawing movements, seesaw movements, and feel that you are cutting the mucosa, and also at the same time you medialize the bone and remove the horizontal part with the Blexley forceps or cut with the scissors, and upper end also we have to cut with the scissors. So this is a cut is made with the sickle knife superiorly, and same thing is continued slowly. See, if you look at, we are medializing the bony part of the uncinate and separating it from the maxilla, frontal process of maxilla. And while giving the cut, you medialize it. And finally, you cut with the scissors. And again, cut the upper part also again with the scissors. Never do it with Blexley. So we should save the mucosa as much as possible, and so that the healing will be good. The next technique is the free salvator. In our institute, we recommend all the beginners to do the free salvator, which is very safe, and especially when the uncinate is bulging or thin and friable. So, and another thing is when the lamina is dehiscent or thinned out, then also free salvator is a better option. So, what we are doing here is insert the free salvator and feel the infundibulum, and again medialize. The fundamental point in doing the uncinectomy is always, while doing, keep medializing. So, and you see the infundibulum space, and if you are not seeing the infundibulum space, you may be in the orbit. You have to be very careful with this aspect. And the next thing is the backbiter technique. We all learn from Dr. Sethi, and this is a wonderful technique, and it's good for the beginners and it's safe. This is a clean and complete uncinectomy is possible easily, and only important thing is when you engage the backbiter, you should see the movement of the jaw of the through the mucosa, through the uncinate. If you are not seeing the jaw movement, the cutting jaw movement, that means you are either in the orbit or you are likely to truncate the nasolacrimal duct. So that is the engage the jaw of the backbiter and give a cut. And mucosal dissection technique. This is the routine technique what we use in our department. Good in the presence of polyps and inflamed mucosa. The procedure is also clean and complete uncinectomy is possible. You will be able to understand the anatomy while doing the uncinectomy. So, using a ball probe, medialize the uncinate and dissect out the bone and remove the bone, and then finally have to retain and elevate the bone from the frontal process of maxilla. So you can use, all this is done using the ball probe, and separate the bone from the inferior turbinate. The uncinate process horizontal part is attached to the inferior turbinate bone with pseudopodia, and the same you have to dissect out. So this is the fundamental technique of doing the uncinectomy. We will go to the video now. Are you getting the video now? Yeah, yeah. Sound okay. So this is a mostly unedited video. The whole idea is to share the difficulties, problems, what we face during the surgery. We always use a 0-degree telescope and for doing the uncinectomy, and for doing the middle metal enterostomy, we'll be using the 30 degrees telescope. So I'm using a 30 degree scope here. I have to look for the natural ostium of the maxillary sinus. When we are using a 0-degree telescope, we should have the straight suction. When we are using the 30 or 70 degree telescope, we have to use the curved suction. You can see the using this. I tried to see with the 30 degree scope, but I could not see. So I shifted to the 70 degree. This is a 70 degree telescope, and you can see the natural ostium here. So this is the natural ostium, and this is a small opening I created in the posterior fontanella, and always use the sharp cutting instruments so that you can preserve the maximum mucosa here. So here, so this is the natural ostium. I'm trying to insert the curved scissors through the natural ostium and give a horizontal cut at the level of the inferior turbinate attachment of the horizontal part of the uncinate bone, and another cut superiorly, either with the scissors if possible. If it is not possible, we'll use the debrider. Please understand that scissors, screw cuts, debrider. These are the three instruments which preserve the mucosa maximum, whereas black sleeve is a grabber and it will make you lose the mucosa, and that is not the goal. So I am trying to insert. So there is the junction. You can see a small piece of bone there. See, that is the junctional part of the vertical and horizontal part of the uncinate bone. And I have seen many people, especially when I do a revision surgery, when there is some narrow fibrosis in the middle metal enterostomy, when you explore it, always you see this part of the bone left out. Unfortunately, this bone doesn't have a good blood supply, and when this is left out, this will turn into ultimately necrose, and this will form granulation, and that granulations will lead to scarring in the middle metal enterostomy. So always you must remove this part of the bone. Okay, I gave a perfect horizontal cut. Now, as I told you, the upper part I can do with the scissors or debrider. So we have done with the debrider. So this is a perfect, and if you look carefully, nowhere the bone is exposed. I will repeat this here. See, watch this carefully, and see here also the bone is not exposed. You can, the mucosa and mucosal contact is achieved. Here also you can see the while making the posterior limitation of the middle metal enterostomy, I preserve the mucosa. This is the sinus mucosa which has been rotated onto the nose. So thereby the edge of the middle metal enterostomy is covered with mucosa all around. So then this is unlikely to contract in the healing process. Since this is a recorded video, my friends can ask me any question. You can ask me to stop and we can discuss. So once we complete the middle metal enterostomy, we have to address the bulla. So here, to address the bulla, I'm going with a 0-degree telescope. So every time we change the telescope, we have to do the focusing and fine focusing. This is very important to have an excellent, good quality image. Now here, so how to do the address the bulla? Always you have to enter the bulla inferiorly, medially, and anteriorly. So that's what I have been doing. Usually I do entire surgery, most of the surgery rather, with the debrider, because that gives me the perfect mucosal preservation. So I am entering the bulla anteriorly, inferiorly, medially. So once I see the lumen, see, I entered inferiorly, medially. When I see in the lumen, then I will extend the debridement further laterally as far as I could see the lamina. So we have entered anteriorly, inferiorly, medially, then we remove the anterior wall, then we are removing the medial wall. And here many times, rather many of the junior colleagues ask me, why don't we do with the black sleeve? The problem when you do with the black sleeve forceps, you will be entering into the nose number of times. Every time you pass an instrument into the nose and do your step of surgery, there will be some trauma to the mucosa of the nose. And this is what we should avoid. So the more trauma to the nose will take more time for healing. And also, black sleeve is a bigger instrument than the debrider, straight hand. So I use the black sleeve only to remove the bone. When I'm not comfortable in the clarity, I'm trying to adjust. Again, I have done the white balance, and I'm using a black sleeve to remove the bone. Only bone. Never remove the mucosa with the black sleeve. Mucosa is to be removed only using the debrider. Now again, that is the ground lamella. Enter the ground lamella also, again in its medial part, medially, anteriorly, inferiorly, because that is the safest way. So this is the point of entry for me to go to the post-rhythmoids through the ground lamella. So again, this is the point of entry, medially, anteriorly, inferiorly. If you go laterally, you may enter the orbit. If you go superiorly, you may be risking the skull base. We don't know where are they. Of course, you can argue that you have seen the CT scan, you know that you have the orientation, but still, this is the way it is to be done, especially for a beginner. So now the moment you see the lumen, you can see that is we are seeing the lumen. So now extend the dissection superiorly as far as you are seeing the lumen. If you don't see the lumen, that means you are close to the skull base. So slowly I would like to replay this part of the dissection. This is the most important thing here. I will explain what I have been doing. So always you, using the debrider, touch the place or part of the tissue which you want to remove and come out. Touch and come out, touch and come out, touch and come out. Thereby, you will be seeing what you are removing. And I will replay again. See, we are going there, removing a part of the tissue. So again, we work lamella by lamella. Right? We have done the anterior wall of the bulla, we have done the post-ethmoid. Now we are entering into the sphenoethmoid recess after completing all the post-ethmoidal cells. See, I am removing bit by bit, and at no point of time my debrider is buried into the tissue. The debrider should never be buried into the tissue. So now we are removing the, so this is the superior turbinate. By removing the inferior half of the superior turbinate, I am entering into the sphenoethmoid recess. So here we have to understand my lateral extent of the dissection of the ethmoid is laterally up to the lamina pepper. This is the lamina pepperaceae, and this is the skull base. Superiorly the skull base, medially the middle turbinate. Can I get the feedback about the picture quality?
Hello. Picture
yes,
quality.
sir.
Picture quality is good, sir. Sir,
Good, okay, sir.
can you show us posterior ethmoidal artery?
Yes, definitely. That is the problem with a recorded video. Usually we don't look at the post-ethmoid, but if it is there, I will show you. So now I have removed the part of the superior turbinate, inferior part. Now I am seeing the natural ostium of the sphenoid sinus. Yeah, yes, this is the post-ethmoidal artery.
Yes, sir.
Yeah.
This is posterior.
Yeah, there is a post-ethmoidal artery. And this is a very small onode type cell is there.
Yes, sir.
And this is the septum, and here is the natural ostium of the sphenoid sinus. Okay, we'll proceed with the video. And when you are, yeah, you can see the natural ostium of the sphenoid sinus clearly. So this is the natural ostium of the sphenoid sinus. Depending on the pathology, for this sinus opening is reasonably good. This is around 2 to 3 millimeter opening. This is good enough, you can leave it. But if the patient history is of repeated sinusitis attacks, that means probably this much of opening is not enough for his kind of immunological reactions happening in the nasal mucosa. So here many people ask me how big we have to do the antrostomy, like middle metal antrostomy or frontal or sphenoid. The answer is it depends on that particular patient's immunological reactions happening in the mucosa. If there are more significant immunological reactions, we require much bigger opening because you are likely to have much thicker secretions and more secretions which have to be drained through the natural ostium. So here, one important thing is while doing the antrostomies or sinusotomy, you have to, you see this is the ostial mucosa. Okay, is it very clearly seen? Now, if I remove the entire this part of the anterior wall of the sphenoid, make a big opening, the problem I am going to face is lymphedema, because the lymphatics travel along the surface of the bone and underneath the periosteum. And unfortunately, in the body, lymphatics cannot regenerate. You can have some new venous channels developing, new capillaries growing big and becoming arterial channels also. But lymphatics cannot regrow. So when the lymphatics cannot regrow, how will the lymph is drained from the mucosa of the sinus? So that will be retained, and that forms lymphedema of the mucosa. And this is the reason you might have seen sometimes you have done a wonderful surgery, the patient is absolutely asymptomatic, and when you do endoscopy, there is no infection, no edema, and when you do a CT scan for some other purpose or something else, they will report as soft tissue density shadow in the sinuses. And if you look at the CT scan, there is mucosal thickening. All that is in an asymptomatic individual is not infection, not sinusitis, that is simply lymphedema. It doesn't cause any problem. But if possible to be prevent, we should prevent. So how to prevent? When you are making any sinus opening wide, you retain at least 50% of the ostial mucosa. So in this case, I have to retain either lateral half of the ostial mucosa or medial half of the ostial mucosa. So since I can do a big sinusotomy in the lateral direction than in the medial direction, so I am preserving the medial 50% of the ostial mucosa and then proceeding to do the sinusotomy. So I am completing the ethmoidectomy. You can see the skull base there. I've gone revise. So that is the skull base. This is the skull base. Now how to identify that this is the skull base? If you look carefully, you can see the horizontal vessels running. And this happens only in the skull base. The skull base can be slanting also. Even then you can identify these vessels and confirm that you can see these are the horizontal vessels running. That indicates that that is the skull base. I am debriding the anterior wall of the sphenoid sinus laterally. This is the left sphenoid sinus, is a small sphenoid, and what I will be doing is good enough. You can see I removed the anterior wall of the sphenoid sinus mucosa. Now I am removing the bone, and finally I will use a punch to remove the mucosa further. And try to retain some part of the, see here I am using a sickle knife, and some part of the mucosa and rotate it onto the nose. This is what I have done. So this is truly the preservation. See, now the neo-ostium is covered with mucosa. There is no bare bone. So this is unlikely to stenose. This is the mucosal preservation techniques. You can see here also, you can see here. I have done a little rewind. I cannot overemphasize the importance of mucosal preservation technique. See, this is what I have been telling you always. This is the sinus mucosa, which I have rolled over the opening what we created. So the healing will happen in this direction and in this direction. When the healing is in horizontal direction, when in these directions, the scarring, the contracture of the scar tissue will pull the mucosa more laterally, and I will not have stenosis of the opening what I have created. So this completes the, up to the sphenoid sinus we have done on the left side. Now usually I go to the opposite side, and at the end I will do the frontal, because by that time there will be some decongestion of the frontal recess, which is very important for me. So again we are using the backbiter. So here again I have done a little rewind. So
Hello.
the technique of using the backbiter is,
Dr. Meghnad.
yes please.
Well, I'm just observing that you're not medializing the this middle turbinate. So it is your usual
No.
practice not to medialize the middle turbinate?
Because I may destabilize it. I don't want to destabilize.
Okay, so you
Only when it is required, I will, when there is no space, then only I will medialize the middle turbinate.
okay, or in case of concha, so you first exercise it and then you go do the middle metrostomy, or you do it first and then you later on exercise that?
No, no. In case of concha bullosa, I will do the, remove the lateral half of the concha,
Okay,
and then I will do the middle metrostomy.
Okay.
That way I will have some space.
okay, good, okay, fine. Okay.
And I will be very happy to answer questions like this. That's how, in fact, we learn more. I will be learning something from you also.
Yeah.
You are most welcome. Thank you very much.
Yeah.
And now at this point, move the, when I'm trying to cut the, with the backbiter, the movement of the jaw, cutting jaw, should be seen through the mucosa, or the uncinate should be moving. If uncinate doesn't move when you are cutting, that means either you have entered the orbit, or you are trying to truncate the nasolacrimal duct.
Dr. Meghnad, can you, for the junior colleagues, can you just define where will be the NLD, nasolacrimal duct, so that they have to be away from that NLD?
Yes, nasolacrimal duct.
That is over.
Where is that? It is not, it depends on the length of the uncinate process.
Yeah.
So when you are doing this, before doing the surgery, you should see the CT scan and estimate the length of the uncinate process, especially at the junction of horizontal and vertical part. Number two, what is the distance between the nasolacrimal duct and the uncinate process? And this is the nasolacrimal duct.
That's right. Yeah.
So if I go, I have taken one bite, I am taking one more bite now. Okay?
Yeah.
And this is the nasolacrimal. It's not easy to injure in every case. In some cases, the uncinate process length is very small, and nasolacrimal duct is more medial. And these are the cases where you are likely to injure the duct.
Fine.
So now after making two cuts, I am removing the vertical part of uncinate using the debrider. And always you do the surgery lamella by lamella. So the first lamella here is the uncinate process. Okay. Now I am removing the medial mucosal layer of the horizontal part of the uncinate. After that, I will remove the bone using a ball probe. For this, I would like to see the natural ostium of the maxillary sinus and then only proceed in that direction. So for this job, I will use a 30 or 70 degrees telescope. Here in this case, the nasolacrimal duct or the frontal process of maxilla is very lateral. Hence, I could not see with the 30 degrees. That was my experience on the left side. So here, straight away I use the 70 degree scope. So you can see the natural ostium of the maxillary sinus. I will rewind here again.
Dr.
This is the
Meghnad.
70 degree scope.
Hello.
Yes, please.
Yeah, how do you, a word on how do you achieve hemostasis and a dry field when you are doing sinus surgery?
Hemostasis during the surgery is by using the 1 in 10,000 to 30,000 diluted adrenaline and 4% xylocaine cottonoids, or currently we are using the surgical sponges, and keep it there for 5 minutes. Go back to the CT scan, read the CT scan and come again. You will get the hemostasis. If 1 in 10,000 is not effective, you can use 1 in 1,000 adrenaline also. Especially if it is not a tumor. If it is a tumor case, if there are granulations, don't use high concentration of adrenaline because it can get absorbed into the circulation. Otherwise, normal, reasonably healthy mucosa doesn't absorb the adrenaline. So now I am with the 0 degrees telescope, and we see the natural ostium of the maxillary sinus. So working with 70 degrees is little difficult, but there is no option for me because I am unable to see the natural ostium. So now I am dissecting out the, see, that is the bone. See, bone is to be dissected out and mucosa is to be deprived. So usually I have a habit of creating a posterior frontanella opening and then join the natural ostium and the opening what I created. For this purpose I will be using a scissors. So this is the curved scissors. Sometimes it is difficult to enter into the sinus. Yeah. So the inferior horizontal cut always I do with the scissors because that is a thicker part of the mucosa and we don't want to have a ragged, lacerated mucosa there. The lacerations in the mucosa will lead to scarring, and the scarring will have non-ciliated mucosa, and on that non-ciliated mucosa the secretions stagnate and they become crust and they cause infection. So again opening the bulla anteriorly, inferiorly, medially, and this has to be like a you cannot forget this. You have to by heart this anteriorly, inferiorly, medially, and look at the lumen, and then finally you remove the anterior wall up to the lamina pepraea and superiorly up to the skull base. And then keep opening all new areas, new cells, always in the same process, anteriorly, inferiorly, medially. And finally, I am removing the floor of the bulla. Where do you share the? next video. Give me 10 seconds time.
Hello.
Yeah, give me 10 seconds time. I will be again with you. No, wait.
These were the basics of FES, and so especially the juniors, if you want to ask questions, come forward and ask. Clear your doubts. A very basic talk on how to approach a case of sinus surgery. So after this, we will have a talk on endonasal DCR by Dr. Sushil Kashyap, followed by a talk by Cochlear Company. They will be talking on auditory verbal therapy, AVT, which is the backbone of for cochlear implant program. By then, we have already a cholesteatoma case which is ready. So Dr. Mishra will be there in the OT and he will take the graft, get ready, and then we'll come live. Dr. Raidu will do the cholesteatoma case. So that is the plan as of now.
Yeah, I'm ready now. Are you getting the video? No.
Sir, one question, sir.
Yeah.
Sir, if we are not used to use 7-degree telescope to open the frontal sinus for the beginners, what will be the best step with 0-degree endoscope?
45 degrees.
45 degrees, sir.
45 degrees scope.
Okay.
But axillary flap technique will help us in doing the surgery with a 30-degree scope in the frontal sinus also. Axillary flap technique. And Caroline's window is the recent addition.
Yes, sir.
But the problem with Caroline's window, you have to do a lot of drilling. And it's very expensive. I don't know many people are doing it, but it becomes expensive because you have to use the drill. The Medtronic drill costs nearly around 30 to 40,000 rupees each bit. And there will be a lot of scarring. It's simple. In the surgery, the more you do, you'll have more trauma and more healing time. So I don't prefer Caroline's window. Simple axillary flap technique is good enough. And another way of doing it is removing the uncinate completely and removing the bone anterior to the or at the anterior wall of the agar incisor. Then also you will get good exposure of the frontal recess. Anyhow, I will be showing all those things now.
Okay, sir. Thank you.
So we are doing again following the same technique, removing the polypoidal mucosa and rather bother whether there is a disease or not, because we have decided to do this surgery, and we see that we have a wide opening to all the sinuses, good ventilation, good drainage, and mucosal continuity.
Dr. Meghnad,
As much.
hello. For a beginner, approach to sphenoid sinus, which approach should he take?
I will pause it here. For a beginner, for the sphenoid sinus, what I have shown in the earlier few minutes back, through the ethmoids, remove the inferior half of the superior turbinate, you enter the sphenoethmoid recess, and then you will see the natural ostium of the sphenoid sinus. Even there is a lot of polypoidal changes there, still you will be able to see the sphenoid sinus natural ostium. And if you do the clean, you will see a vertical slit-like opening. In case of pathology, when the pathology is less, you may see an opening. So again, we are opening these cells anteriorly, inferiorly, medially, and proceeding to identify the lamina peperissia laterally and skull base superior. And this, whenever you reach the skull base, you will start seeing the horizontal vessels. That's an indication that you are on the skull base. And the medial boundary of dissection is the middle turbinate, the lateral boundary of dissection is the lamina peperissia. So now you see this is the superior turbinate. I am removing the inferior half of the superior turbinate. Here I am using the debrider, but many times I use the scissors as well. Every time I am focusing, I am checking the focusing, but that is very important for me to identify the structures. See, I am using the scissors here. So after making the cut, I am removing the bone. Now you can see the natural ostium of the maxillary, sphenoid sinus. That is the natural ostium of the sphenoid sinus. See, if you see, I extended the sinusotomy laterally, and you can see the ostial mucosa of the sphenoid sinus is very well preserved. This is very important for me to have a good healing and good long-term outcome. And widen it superiorly up to the skull base, or little away from the skull base, and laterally little away, at least 3 to 4 millimeters away from the lateral wall of the sphenoid sinus. So this part I prefer using a cutting instrument like punch. Remember, punch, through cut forceps, scissors, debrider. These are the cutting instruments. And you may have seen me using the black sleeve maybe 3 or 4 times till now. That's all. It's only to remove the bone pieces rather than doing the surgery with black sleeve. See, again, touch and go, touch and go. Don't allow the debrider tip not seen for few seconds. See, there is a little paradoxically covered middle turbinate. Even then, I am not bothering about it. I am not doing anything for that. Some purulent material, I have sent it for culture sensitivity. And always keep the field, including nasopharynx, clear from the blood, because blood is an irritant to the nose and nasopharynx, and by keeping it as less blood as possible, the post-operative pain will be less. So with this we have completed the both sides sphenoid, both sides ethmoidectomy, both sides middle metal and prostate. So give me again 10 seconds time for the good flow of videos. I have made the video into 4 parts. I will close it. Yeah. Okay, now we are on the left side front. So now I'm with the 70 degree telescope using a, no, this is the right side frontal, using a through cut forceps. I'm removing the partitions in the frontal recess. Now, little understanding of anatomy here. I'm rewinding. Yeah. See. So this is the middle turbinate. This is the skull base. This is the lamina peperosa, and probably here somewhere is the frontal beak. So I have this much of area to work. In the frontal recess or anywhere, we remove the septations with through cut only. Sometimes if the mucosa is little soft, it may not be able to cut, and then after giving the cut, we use the RAD 40 blade to clear the septations. That is not the anterior ethmoidal artery bead, that is the recurrent anterior ethmoidal artery. Recurrent artery. So we are removing the partitions laterally up to the lamina peperosa. Yep. The problem with 70 degrees is you will have a little low quality of picture. The field gets smeared with blood very often. Frequently you need to clean the endoscope tip, but that's part of our life.
So in this area, while approaching the frontal, how do you avoid the anterior ethmoidal artery?
So you have to identify the anterior ethmoidal artery and then work in that region. Now the other way is identify the frontal beak and work posteriorly. That is also another way. And always on the CT scan you have to estimate the distance between the anterior ethmoidal artery and the frontal beak. Once you have estimated that, you know where you are. So we will identify the anterior ethmoidal artery in each and every case, and then we'll proceed with the surgery.
And do you like the intact bulla technique, or you approach the bulla first and then the frontal?
Intact bulla is good if bulla is not very well developed. If the bulla is very well developed, protruding anteriorly, bulla will keep hitting the endoscope and we will have the problem. See again, I follow the technique depending on the situation. So here, how to go ahead with the 30 degrees without using the 70 degree scope in the frontal, that was the question. So now we have the answer here. See, this is the part of the uncinate process. See the frontal recess now, and what I am doing with this. I am using a punch, curved punch, and see, suddenly you see the entire frontal recess is white. This is something like axillary flap technique. The axillary flap technique, you are saving the mucosa and rotating the pedicle flap, and the result will be excellent. See, you can see the structures very clearly now. You have exposed the agar cell. Already you are seeing the frontal sinus. So a complete uncinectomy itself will give a wonderful outcomes in the frontal recess. So I am not finding any difficulty in using the 70-degree scope because I have a wide frontal recess.
Dr. Meghnath, in the morning we saw Satish using debrider and cobbulator alternatively, using the cobbulator for bleeding. So do you use coblation in the nose that frequently for routine sinus?
I do use, but debrider is the best. But if you want to show a beautiful field, you can use the cobbulator. If you want to show a beautiful post-operative outcome, you should use the debrider. I think I am clear.
Yeah, and using cobbulator then post-op crusting and other things would increase?
Will be more. Will be more definitely.
Yeah.
Now you see here. So this is the anterior ethmoidal artery. Like this here, it is the anterior ethmoidal artery. And this is the supraorbital cell. Okay? So removing all these partitions, identifying the skull base, and in relation to the anterior ethmoidal artery, and remove the partitions laterally up to the lamina papyracea, superiorly up to the skull base, medially up to the middle ear. If you want to have a very, very long-term excellent outcomes, the mucosal preservation is very important. And in a sinusitis surgery, I don't use coblation except for hemostasis as a bipolar. See, all these bone pieces, see, I am adjusting even the mucosal layers so that there is no bare bone is seen. To preserve the mucosa as much as possible, I will use balloon also. So balloon is the most mucosal preservating instrument. So that is the supraorbital cell. I will rewind. So this is the supraorbital cell, and this is the anterior ethmoidal artery, and this is the frontal beak. So all this area, if you work here, you will identify the sinuses and frontal recess cells present there. In fact, this I am showing the left side frontal recess dissection because this is the difficult anatomy here. You can see the thick mucin, the epicenter of the disease in this patient is the left frontal recess. I have to work very carefully here. I would like to identify here, this is the middle turbinate and this is the uncinate process. Uncinate process, complete uncinectomy is going to open the frontal recess as well. This is what I have been telling. So this is the uncinate process still left out. So we are removing the cells layer by layer. So that is the uncinate process. This Medtronic RAD 40 blade is a rotatable head, and I am able to remove the uncinate completely, which is a vertical partition. So at this point, usually you get a little more bleeding because the anterior rethmoidal artery, after coming out from the intracranial cavity into the nose, it will come there. So you are likely to have encounter a little more bleeding there. All these bone partitions are to be removed without leaving any one of them. I think we have another 2 more minutes time. So if I use the black sleeve only to remove the bone, and again with through cut. So you can see here now, this is the anterethmoidal artery, supraorbital cell, and this is the frontothinus.
Dr. Meghna, the word on your pre-op protocol and post-op protocol.
Yeah. Just give me 1 more minute. We'll complete this. Then we'll go. That is very important. And my pre-op protocol and post-op is little controversial, but if you look into the literature, what I am doing is quite correct.
That is why I wanted the junior colleagues to hear this.
Yeah. So preoperatively, we always give maximal medical therapy. The maximal medical therapy is directed by the cultural sensitivity reports, and you have to give for long term. There is no role of 7 days, 10 days antibiotic courses in chronic sinusitis. In acute sinusitis, that is good, but not in chronic sinusitis. In chronic sinusitis, the antibiotic has to be for more than 14 days. And you give steroid nasal spray, steroid saline douches, and sometimes I use clarithromycin or azithromycin at a low dose, single day dose, and at least for 40 to 45 days before the surgery. And my juniors keep telling me, sir, you are given 45 doses, he got this antibiotic, he got release, he is not coming for surgery. Very good. This is the complaint from my juniors, but that's how we can reduce the requirement of surgery.
Oral steroids, sir?
Steroid nasal spray. No oral steroids in a chronic sinusitis of bacterial order. In fungal sinusitis, I prefer using the antifungal and low dose steroid. I prefer using high dose short course compared to the long duration of steroids.
And any preference which steroid?
Deflazacort is my preference because that has less mineralocorticoid effect.
And you use 30 milligram OD or less?
30 milligram per day. And in very severe cases, I use 30 milligrams in the morning at 7 o'clock and at 3 p.m. This is how you will have the minimum, lowest effect on the pituitary hypothalamic axis. This is my preoperative regime, and after this maximal medical therapy, we'll wait for another 1 month, and if the patient is asymptomatic, we'll ask him to continue whatever may be the CT scan, unless it is an impending complication, and then we'll continue with the antihistamine and steroid, intranasal corticosteroid spray for 3 to 6 months. If the patient is asymptomatic, on endoscopic examination, if you don't see any purulent material or mucoid secretions, we will keep him under follow-up. But if he gets the problem again, complaints again, either either symptomatically or on the findings wise, then we will go for the sinus surgery. The post-operative protocol is again culture-directed antibiotic for 15 to 45 days, depending on the type of organism and antibiotic. For example, if most of the cases we have seen is the Pseudomonas and gram-negative bacteria in chronic sinusitis, unlike acute sinusitis. And in these cases, if the Cipro is sensitive, we use the ciprofloxacin for at least 45 days. Because until the mucosa to mucosa healing happens, I should not see any bare bone to stop the ciprofloxacin. If there is a bare bone, if Cipro or antibiotic is not given, there is a chance of osteitis, a newborn formation there, and biofilm formation. To avoid that, I will give the ciprofloxacin for 45 days, along with nasal douching, either with a clear saline or mixed with budesonide.
Dr. Meghnad, how much the stay is there with the first patient? Stay in the hospital stay?
Typically, patient will stay for 1 to 2 days, and I keep the pack for 5 days.
5 days, okay.
5 days. On 5th day, I will remove the pack, and I will call the patient every day for about 4 to 5 visits and see that there are no synechial formation. If there are no synechial formation, then I will say bye-bye, and I call him after 6 weeks, and then onwards once in 6 months.
So a revision of the post-op protocol, antibiotics, steroids, nasal douching, right?
No steroids.
No steroid, okay.
Topical steroids at the most.
Topical steroids, and then 5-day pack, nasal pack.
5 days. 5 days.
And then after 5 days pack, a daily visit to see any synechial formation and all, and if everything is in place, then see him or her after 1 month or so, right?
Correct.
And Dr. Meghnad, as far as the steroid are concerned, pre-op, as you are saying, you use steroid. If the patient is a comorbid like diabetes or hypertension, then any change in the protocol or anything like that? If the patient is diabetic or hypertensive or?
I will give less dose of steroid.
But you will, definitely.
Yes.
Okay.
And we'll step up the anti-diabetic medication.
Okay, and the pack you use is Mehrotra
Yes, Mehrotra.
for 5 days.
Yes.
Okay.
Sir, isn't it very uncomfortable because 24 hours patients don't tolerate Mehrotra, they want it out immediately. 5 days becomes too much.
First 24 hours they don't tolerate, sir. Second, third, fourth day they will behave. They get used to it.
So 5 days of pack and then nasal douching and 45 days of antibiotic.
Yes.
Okay. And antibiotic will be culture directed.
Culture. See, sir, again it depends on the bacteria, sir. If it is Pseudomonas, 45 days, sir, because it's a very stubborn bacteria. For example, if it is E. coli or Klebsiella, 14 days, 20 days is enough.
Sir, and
Or
all,
if
yeah.
it is negative, then I presume it is a pseudomonas and I give 45 days of antibiotic, ciprofloxacin.
Sir, and lot of these patients are allergic. So, what is the protocol for allergy? Do you go for allergy tests, flu vaccine, or how do you deal with that? Or immunotherapy?
Sir, if I can control the allergy symptoms with antihistamine and steroid spray, then I don't go for the immunotherapy. But my threshold for doing a skin prick test is very low. The one reason is I've seen many patients. I'm having allergy, so I will not take lemon. I will not take any citrus. I will not take dahi. I will not take milk. I will not take ice cream. They will have a list of things which they don't want to take because they are having allergy. To disprove that belief, I do the SPT and tell them, you are not allergic to all these things, you are allergic to only the smites, please take. Take a normal diet.
And Dr. Mehrotra, are you doing immunotherapy?
Yes, yes. I do use immunotherapy in case of fungal sinusitis where it is the allergy is more, allergic mucin is more, in spite of the antihistamine and steroid spray, I give immunotherapy.
So which immunotherapy? Skit or slit?
Slit.
Slit.
Sublingual.
Slit, sublingual.
And experience with biologics?
Sir, you are not audible.
So the biologics, the other medication for which is immunotherapy, do you use that?
I don't have any experience of using the biologicals till now.
Because they are very expensive also, and I don't think readily available.
Your audio is getting interrupted. I am stopping my video so that I can have a good.
Yeah, can you hear me?
Yes, I can hear you now.
Yeah, so these biologics are expensive and also not readily available, but they are used. They are being used in western part of the country. So
Yes, yes.
maybe I think future we will be using it.
Definitely, biologicals have a great future. That's my opinion. For example, I'm not using in chronic sinusitis, but I'm using in the other conditions like recurrent laryngeal papillomatosis, bevacizumab.
Okay.
Wonderful results. So biologicals have a definite role, but only thing is the technology has to prove. I think in the coming decade, we'll have a wonderful biologicals available. Definitely, we'll be enjoying the use of these biologicals.
Perfect. Any further questions, anybody? So thank you, Dr. Meghnad. We missed you here, but we had a very good live lecture and with the video from you. Thank you so much.
I missed the great conference, but definitely next year I'll be there.
Thank you, sir. Thank you so much.
Thank you for giving me this opportunity. Thank you very much.
Thank you. Thank you so much.
Thanks.
Next, we have a lecture on endoscopic dacrocystorhinostomy by Dr. Sushil Kashyap. I would like to call Dr. Praveen Saxena sir to introduce sir.
Good evening, everybody. I would like to call Dr. Kashyap sir, HOD Medical College Jhansi. He is one of my mentor, my teacher of my college days. So it's my big pleasure to call him on stage for his lecture. Thank you. For dicing this chair, Dr. A.K. Srivastava sir, Dr. Pavan Kaul sir, Dr. Vijayan Shukla sir, please.
Hello. Very first, I would like to thank Dr. Mehrotra for inviting me on this workshop, and we had a good session and video in the morning. And this, I would like to present, have a little talk on the endoscopic endonasal DCR. As everybody knows, DCR is usually done in a pass by the ophthalmologist. That is external DCR, but nowadays it is routinely done by the ENT surgeon. When I was working in Nanavati, that first time I heard that some ENT surgeon is doing endoscopic DCR. That is around 25 years back. So since then, the technology has evolved a lot. So nowadays we are doing endoscopic DCR routinely. But challenge, difficulties, and that we should know. And for any surgery, to understand surgery, the very first thing we should be aware about the anatomy. If we see the lacrimal apparatus, it consists of two parts, lacrimal gland, duct, and another is draining area, draining part. That include lacrimal punctum, lacrimal caniculi, that is superior, inferior, common canaliculi, lacrimal sac, and nasolacrimal duct. It has a bony and membranous part. And there is a valve of Henson. There is a little bit detail about this and the anatomy. These are the glands which this located lateral and superior part of the orbit. Through the duct, the tear drained into the eyes, and that through the eye, it goes to the draining system and finally drain into the inferior meatus. These are the few valves. Why there is a blockage? There are few particular areas. There is a valve of Henser and two is the valve of the Rosenmuller. These are the two areas where you commonly get the obstruction. So if there is any stenosis of this valve area, and that will lead to the collection. The most important thing to understand to do this surgery is to understand the lacrimal bone. There is a location of the lacrimal bone on both sides, from the orbit side as well as from the nasal side. As you see here, from the nasal side, it is just located anterior to the middle turbinate. And here you see on orbital side, you see it is located just posterior to the frontal process of the maxilla. As you see, there are a few endoscopic pictures. As we see here, this is the maxillary line. We see the dotted line, and this is the in area of the interest anterior to the lamina papricial. This is area of the interest where you have to perform your surgery. Now, the watery eye. After the anatomy, watery eye is not only caused by the obstruction of the NLD. It can be due to the excessive excessive lacrimation. So, it is maybe so that you have to rule out either this due to the any mechanical obstruction or is only the physiological. So, that will help you in selection of the cases. If your case selection is not good, obviously result will also not be good. And this is result oriented surgery. So, if we see the epiphora, there are few common causes like a mechanical obstruction. There can be obstruction at the puncta, canaliculi, lacrimal sac and nasolacrimal duct. So, there is 4 point you will get a mechanical obstruction. And there is a physiological obstruction that you have to rule out like the laxity of the lower eyelid. That also can you can have a epiphora and weakening of the orifice oculi muscle. How will you differentiate these mechanical and physiological obstruction? This is by the history. This is by doing the examination, few clinical tests and radiological tests. If you go to the history, this is unilateral watering or bilateral. Unilateral commonly due to the any mechanical obstruction. This obstruction can be at any side of the drainage system of the nasolacrimal duct. And there is a bilateral, this is usually due to the excessive lacrimation. This may be due to the infection, some allergy. And the same thing you will get in children also. How to make a diagnosis? These are the few things on examination you have to do. You have to check the lower lid laxity, any ectropion, entropion, punctal eversion, and that you have to do some lacrimal sac if the enlarge is there. You have to do the palpation also, and this palpation will normally tell you about the where from the pus or secretion is coming out. These are the few clinical tests. There is a lacrimation sac, palpation or lacrimation, syringing, probing. For the endonasal DCR, there is another examination you should do is a nasal examination. Is there any deviated nasal septum? Is there any concha bullosa? Is there any sinusitis is there or not? That also you have to rule out. The radiological test, there is a dacrocystogram. The basic test that you put the dye into the sac and take the X-ray. That will tell you either there is an NLD block is there or not. The CT scan and CT scan is to be prescribed if there is any dacrocystocele, or if there is any doubt, you think there is any tumor is involving. So that for you need a CT scan and MRI done. There is another investigation. This is dacroscintigram. This is we use the technetium 99. We instill in the eyes and we use the gamma camera and see the traces either they are going into the nasal cavity or not. If it is going in a nasal cavity, that means there is no obstruction. This is a clinical test. The most common test to diagnose is do the syringing. That syringing commonly done through the inferior puncta, or you can do by the superior puncta. These are these are the findings will help you to make a diagnosis. If the water is going into the oropharynx, there is no obstruction. If the water is going to the oropharynx also, or is coming through the superior, another canaliculi, if you are doing through the inferior, if it is coming through the superior, there may be a partial obstruction. If it is not going to the oropharynx, if it is coming through the another canaliculi, there is a complete distal obstruction on NLD. If it is superior, it's negative to the oropharynx and superior, it is coming to the superior caniculi without secretion. This one is with secretion, one is without secretion. Then there is an obstruction of common canaliculi. And if it is coming with the secretion, there is common NLD. There is obstruction at the level of NLD. So there are two things. Are they coming with the secretion or without secretion? So if you push water, if they say the collection of the secretion in nasolacrimal sac, that will come out with the water itself. If it is not going to the oropharynx and coming through the same canaliculi, there is obstruction at the level of the inferior same canaliculi itself. If you see this picture, you can make out. This is, if it is water coming from the, another canaliculi, this is obstruction at the common canaliculi. If it is water is coming from the same canaliculi, same puncta, there is obstruction of the same canaliculi. And if it is water coming with secretion or without secretion, if it is coming with secretion, there is obstruction of nasolacrimal duct. Second is probing. This will differentiate the obstruction at the common canaliculi or obstruction at the level of NLD. This is by the hard stop and soft stop. If there is a hard stop, that means you can negotiate the common canaliculi and reaching up to the fundus or reaching up to the sac and hitting the bone medially. But if you see the soft stop, that you are not negotiating the common canaliculi, you are hitting the bone with common canaliculi, that you will feel soft. That's how you can differentiate. This is a picture of dactylocystogram. This is dye we can see at the level of the sac. There is no dye going into the inferior meatus. So this is a good case because the sac is big. You know, if you make an incision medially, obviously it will not hit the lateral wall, and obviously there is a pus will be there, the collected secretion will be there, and post-operative result will be good. In some cases, you will not find that much of the big sac that can be fibrous, and these are the difficult cases to be operated, and especially the recurrence are more. The CT scan, you can get CT scan axial coronal, but if there is more information, you will get if there is any tumor or any dactylocystocele. That will let you know either dactylocystocele is it connected with the sac or not. If it is not connected with the sac or is it lie lateral to the sac, then you have to give the incision on lateral wall as well. Now question come, why endonasal DCR? Because very first thing, no facial incision. And second, also most common, the preservation of lacrimal pump function. This is also the one of the most important thing. Third, you can also, same sitting, you can treat the simultaneous contributing factor like oncobulosa, short recovery time, and outcome is comparable or even better than external DCR. These are the few indications for the endonasal DCR. We can do, there is the most common is the primary NLD obstruction. It can be done with secondary. This obstruction secondary can be due to the dacrocystocele itself, and other thing like the trauma and neoplasm, and recurrent dacrocystitis. This canalicular obstruction can also be tackled with endonasal DCR. How to do? These are the few points. Position of the patient, how to put the patient on the table, preparation of the patient nose, identification of lacrimal area, infiltration of the nose, surface cautery of surgical area, incision, elevation of the flap, bone removal, identification of the sac, incision in the sac, marsupialization of the sac. This much has to be done in every case. Now, this additional thing like placement of stent, this is optional. That you have to decide the which cases you require stent, which case does not require stent. Placement of Mehrotra lacrimal pack. That we place one small pack inside the lacrimal sac through the neo-ostia. That to maintain the neo-ostia patent for longer duration. That can avoid the synechia and stenosis. And nasal packing. This, I keep the patient supine with little extension of the head. The identification of the lacrimal sac area, this is axilla of the middle turbinate and maxillary line that mark the position of the NLD. What is maxillary line? Maxillary line is just a junction of the frontal process of the maxilla with lacrimal bone. That you will see as a bulge in the nasal cavity. As these are the picture you can see, this is the area. As blue you can see this is lacrimal bone and this is yellow is the frontal process of the maxilla. On endoscopy picture you will see the same. The nose has to prepare with the first packing of this area and packing rest of the nose, and after that we will do the infiltration of that area. If there is any nasal septum is there, we have to deal with the nasal septum. If the concha bullosa is there, then we have to do the bullectomy. This is surface cautery and some steps of the video. That I used to cauterize the mucosa of that area that's anterior to the middle turbinate. That helps to reduce the bleeding when we elevate the flap. So if there is less bleeding, the surgery time will also be less. If there is more bleeding, then you have to do the cautery at the bone. And then you have to keep the pack for the longer duration. So this whole of the mucosa has to go. So this part of the mucosa, thus we have to do the bipolar cautery. I use 50 number blade to give incision. This is an unedited video, so there is some less useful part. This is the incision will give. This will locate the anti-attachment of the middle turbinate. We give a superior incision just above that, the anti-attachment of middle turbinate, and we give anterior and posterior incision, and they connect this anterior posterior incision inferiorly as well, just above the inferior turbinate. And this we start getting the bone. Now I used to take this part of the flap out. I don't keep this flap back. These are the few pictures showing the elevation of the flap. We elevated the flap, and this is a completely removed mucoperiosteal flap. Now we see the whole of the bone. This is this is lacrimal area, which is the frontal process of the maxilla as well as lacrimal bone. There is another case. In which this is how to remove the bone. This is take your DCR punch, go most inferiorly. The most inferiorly you will get one slit like opening in between the bone. Engage the DCR punch, then is punch the bone out. That is from posterior to anterior direction. And immediately you will see the periosteum on other side. This bone has the periosteum the nasal side as well as on orbital side. As we see, this superior part of the bone is thicker as compared to the inferior part. Sometimes it is difficult to take out with the DCR punch. So this area, if it is not able to amenable with DCR punch, you can use the DCR drill. Drill might be required to this part of the bone. To confirm, as you see that there is a movement. There is a movement of the soft tissue is here. This assistant is pressing over the lacrimal. This is medial part or on the lacrimal sac from externally, and that pulsation we can see the inside the nose. That we confirm that we are inside the. This is the sac. After confirming that this is a sac, that we can remove the more of the bone superiorly, which you can see the one piece of the bone is overhanging, that has to be removed. This bone removal has to be done at the level of the anti-attachment of the middle turbinate. This part of the bone can be removed by the just medial movement of the tip of the DCR punch. If you don't have the DCR drill, or if you don't have the drill at that time, you can use this maneuver and to take this bone out. And this is frontal process. This is sometimes difficult to take that out. As you can see, this you cannot punch it out. The DCR punch will not go inside. So you can move the tip of the DCR punch medially, that will whole bone will come out. We can use the Blacksley to take this bone out. Okay, next slide. So you see here there's a picture number 1. We're showing the area, the cut, and in the picture number 2 you can see there's one bulging is there. How to confirm it? This is sac or not? The very first thing I told that to give the pressure medially from the orbital side, you see that there is a bulging is there, and put the probe. The second is, if you put the probe, that through the common canaliculi, you can see that probe. And this bulging is there, you can see the still pointed end. This is the probe. Can you see the probe? The third thing, you can just put the dye before starting a surgery to the inferior puncta into the sac. That will appear the blue, as you can see here in third picture. In that side, the first picture, you can see the after opening, there is a blue fluid is coming into the nasal cavity. As you can see, this picture is showing the sac, and this is the sickle knife. I am using the sickle knife to give the incision, and after giving the incision, we can see the pus is coming out. But in some cases, pus does not come out, and these are the really tough cases. If the sac is having the pus, obviously pus will be drained. If sac does not have the pus will not come out. So in that case, the probe will help you. If you put the probe and push the medial wall of the sac medially, and then you give incision, that you will see the cavity of the sac, and that you will not puncture the lateral wall. In most of all the cases, you have to keep this lateral wall intact. You should not puncture it. This is the widening of the sac. This is widening on the both sides. And now I put this Mehrotra pack for at least 1 month in situ, 21 days to 1 month. Depend on the patient. I am showing the video of one patient, recent patient. We did the endonasal DCR, and this is a post-operative case. This is post-operative video. As we seeing, there is a wide opening is there. When you press from the orbital side, without syringing, we can see the only by pressing the fluid is coming out. This is another same video, post-operative video. That we are doing syringing, that fluid is coming out through the neo-ostia without pressure. We have done in last 3 years more than 50 cases, and out of that we have failures of 2 cases also. And that in 20 cases, few cases we did not keep the any pack, DCR pack, and 20 cases we pack the DCR pack, just lacrimal pack, and we see there is any difference or not. Is there any reduction in the stenosis of the neo-ostia? There was a difference. This is, you can see the one case, this is a case of dacrocystocele. That we did through the nasal route. We do the DCR and they take out the multiplies the whole of the dacrocystocele. Unfortunately, I don't have video of this patient. And this is a one video, the few video of that surgery. This is unedited video. This do not have much time, so I'll just fast forward it. This is just infiltration of the gyrocane in the sac medially to reduce the bleeding. I always confirm all the time. I always confirm that we are giving incision in the sac. You can see that there is not much fluid has come out, but we are inside the sac. You can see the wide open sac. To confirm the sac, that we put the dye into the sac to see that when we open the sac only. As you see that there is bluish discoloration is there. This is another video. This step I have already shown you. As you see here, there is a pus is coming out after the incision. You see the movement of the sac when you press either by the valve probe or by the finger. As you see that the gush of the pus will come out. If the collection is there in sac, that the gush of the pus will come out, that will confirm that you are inside the sac. If there is a pus, obviously the sac will be widened. It is safe to do the marsupialization in such cases. And this is how to widen the opening of the sac. We confirm by doing the syringing that to check the patency, and it's by the probing also. You can see the probe. You can see this probe is coming out. This is DCR probe we have put through the orbital side. While doing the DCR surgery, it's very easy, but you can tackle the few challenges. These few challenges are you know the anatomy. The very first thing, you should know the anatomy, and second challenge is removal of the thick bone. Identification of the sac, especially in a fibrous lacrimal sac. The prevention of the stenosis, this is post-operative. And that regular follow-up sometimes become difficult. Success of the endonasal DCR depends on the size of the osteotomy, complete sac marsupialization, canalicular patency, stent placement plus minus. If there is a common canaliculi obstruction, or if there is a sac fibrosis, better to go for stent placement. If there is a common dacrocystocele, there is an NLD block, obviously there is no need for stent placement. Mitomycin C application. Then through the endonasal DCR, we can soak the Merocil gel form, a small piece of gel form, and we can put this through the new ostia and keep it there at least for 7 days or 10 days. And so this is placement of the Merocil pack. Depending on the tolerance of the patient, you can keep 21 days to 30 days. Regular follow-up and selection of the cases. Why DCR fails? That you should understand. This excessive intraoperative bleeding. The very first thing you have to deal with the bleeding. Every time with the blood come out, it is difficult to operate. This is incorrect sac identification, incomplete marsupialization, post-operative granulation, re-stenosis and synechia formation. This is modification of the surgery. You can use the power instrument or laser assisted DCR. There's a few new things are coming in the DCR that can also be used. Thank you.
Very well explained, nice illustrative talk by Dr. Kashyap. One can welcome any question if there is. Yeah.
Is there any added advantage of putting Merocil soaked in mitomycin C? I am putting the Dexona instead.
Sorry, I didn't hear you.
Any added advantage of putting Merocil soaked in mitomycin C instead rather than putting it soaked in Dexona?
The last case I show you, this is the healed neostia. That was the case we put the mitomycin soaked this Merocil in the neostia.
No,
that helps in reducing the re-stenosis.
Okay.
How
it reduces the inflammation or what?
Yeah, it reduces
but the same thing.
Mitomycin C itself, I've just started. Okay. Mitomycin C previously also used by ophthalmologists. They use ophthalmologists in DCR. So they put through the whatever the opening they make, they apply the mitomycin C. They just apply it and take it out.
Okay.
They just apply it and take it out.
But I'm using Dexona instead. Is there any disadvantage of using
Dexona? I have not used.
I'm using it. I'm getting the same results.
Maybe, because Dexona itself it also reduces the inflammation.
Yeah. That's why I am asking. Is there any added advantage of using mitomycin?
The mitomycin C reduces the re-stenosis, the fibrosis.
Okay.
That reduces the fibrosis also.
Okay. And do you use this surface cauteries in every cases?
Every cases.
Okay.
Because
And-
it reduces the bleeding a lot.
And you've taken the incision all around, and you've taken the mucoperiosteal flap from the bone, lateral wall of the nasal wall.
For first I give the incision all around, then
Okay.
I'll take it, then elevate the flap.
Flap, you raisen the flap from all around, and you deposited it back, or
No, I take it out.
the bone is bare all after
Well,
that?
obviously it heals. The mucosa grow back very fast.
Okay.
I have not seen any bare bone later on in post-operative period.
Okay.
Till
And
now.
when you remove this mitomycin soaked Merosil pack
After 7 days.
after 7 days, and you have said after 21 days,
That is plain Merosil pack we used to keep.
okay.
That to just to same thing, a plain Merosil pack, a small pack, with that we remove after 21 days.
Plain means I could not.
Not soaked in mitomycin C.
Okay.
On some cases I have kept
So
that.
how do you decide we have to put plain Merosil or soaked in mitomycin C?
Just like if there is a pus is not coming out,
Okay.
there is a fibrosis. If the chances of fibrosis, better to go for a mitomycin C soaked.
Okay.
Because
So if pus is there, then do you simply put the
if a pus is there, that the
plain Merosil.
simple Merosil pack can be.
Okay. Okay.
If there is fibrosis also there, then you can additional stent to be placed.
Okay.
Stent will also reduces the chances of the restenosis whole of the pathway.
That is
Start
right.
from the puncta to the neosteal.
Okay.
Because that is very small canal that can be restenosed anytime. If like in probing, we can traumatize the common canaliculi, we can traumatize inferior canaliculi, wall, that can obviously
Okay.
restenosis.
Sufficient. More
And
than.
patient will again have same problem.
Okay. Next.
Thank
Next what?
Thank you.
Can we start the case? Just talk. Bole.
For 7 days and a plain pack used for 21 to 30 days.
21 days.
21 days.
Depend on tolerance to 30 days.
Is it stay for that long?
Yeah, it stays. No, I put the thread and that thread I'll add a stick on the
Okay.
dorsum of the nose.
You fix it
Yeah.
with thread.
That we can easily just pull it out post-operative period. Without endoscope, we have to just pull it out.
Okay. Thank you. Thank you.
Any question?
And we can go ahead for the next lecture.
Thank you, sir, for such an incredible presentation. It gives me great pleasure to now invite our esteemed faculty member, Dr. Jaspal Chaudhary, sir, to the stage to deliver their talk on the role of auditory verbal therapy. We look forward to gaining valuable insights from their rich experience and expertise. Please join me in welcoming Dr. Jaspal Chaudhary, sir,
Wow.
with a warm round of applause. Okay, it will be an online program.
So Ms. Jaspal Chaudhary is a renowned speech therapist, auditory verbal
Now the
therapist
Jaspal Chaudhary talk.
with Cochlear Company. She is
Jaspal Chaudhary
based in
talk is going
Mumbai
on.
and she takes
Wow,
lot of
she takes so much time. What to do now?
classes, if I may
Tell me.
say, for surgeons. And Jaspal, can you hear us?
Yes, sir. Thank you very much.
Welcome to our workshop, and I can proudly say that I am one of your students, having been taught AVT to me, and every surgeon who does cochlear implant surgery must learn about AVT, because without AVT there is no cochlear implantation. Over to you, Jaspal. Go ahead.
Thank you, sir. You have said everything into words. You people have been hearing so far about surgery, but before I talk to you, I want to thank Dr. Mehrotra. Dr. Mehrotra has given me this opportunity to talk to all of you on one platform and not being physically present there. Thank you, sir. Thank you so much. What I'm going to talk about is what is beyond surgery. Now that you realize that you as a surgeon are very important and you are giving auditory access to the child for all the sounds and language which the child did not have. But is it the beginning and the end? No, it's only the beginning. How do we end it? When you give that opportunity to the child to listen to everything, then after that the child has to go through LSL training through AV techniques, that is listening and spoken language training through auditory verbal techniques. So how do we do that? What is AVT? So let us see. I will share my screen with you. And let me know when you can see that. One minute. Can you see my screen?
No, still not.
Okay, just a minute. I'm going back there. Can you see this, sir?
Yeah. Your screen is there now.
Okay, so what we are going to talk about is why AVT? What is auditory habilitation after CI with children? The children who get cochlear implant, they can hear everything now. They have an auditory access to all the sounds and language. But do they understand what they are listening to? Because earlier they were not listening full sound, full sounds, all the sounds and all the language was not available to them. So most of the time either they were not hearing or they were misunderstanding. So then we have to go through auditory verbal therapy. The question is, I will just go through quickly about this. What is auditory verbal therapy? Why should we do it and how do we do it? So when we are talking about what is AVT, it is a scientific system. Some people think that we are just sitting and talking to the child or playing with the child. It's not that. It's very systematic, very scientific. Hierarchy steps are there which we follow when we talk to the children and we talk to the parents. This program gives systematic instructions to these children so that they can learn the process of speech and language through audition and not through lip reading or the flashcards. So how do we do that? We do it through parents. You see, the children who are less than 3 years old, they learn language, they learn to use spoken language communication. How? Even their grammar is perfect. They don't make any mistakes in their home language because this is what the parents had been talking to them. And this is AVT is based on the same exercise, how our brain learns language. So I will be taking you through some research findings also to make you understand what I am talking about. So hearing is first order event and it has to lead to spoken communication and also literacy skills. Here I ask you a question. You were talking about you have 50 children surgeries done. Can you say out of those 50, how many are going to land up in the regular schools and will get education along with their peers of the same age? And how many will not be able to use spoken language communication completely, will not be integrated into the society completely? Yes, they will be able to communicate, but they will be still using gestures and visual tracks. So what we have to think of is auditory brain development. When we are talking about AVT, we are talking about younger children. The children who get cochlear implant before the age of 4 years, by the age of 3 years, they will learn language faster. But the children who get cochlear implant after 4 years will go very slowly. The children who get implant after 5 years may not be able to go to the regular schools. And some people don't like it when I say that why are you wasting money on a child who's 6 and 7 years old? Let him learn sign language, let him do literacy skills. He or she cannot develop natural spoken language communication because it's past the auditory brain development now. Acoustic accessibility is very important, which the children did not get immediately after birth, and therefore this is going to hamper their spoken language. So why should we do AVT? It's a very, I will show you a very small video here. Maybe just 2 minutes video, which will help you to understand why do we need to do AVT. So let me know when you can see this video. It's about, and you just tell me what can you make out of it? What have you learned? Can you see this? Yeah?
Слав 4,75 часа лигурийский регулировщик регулировал в Лигурии, но 33 корабля лавировали, да так и не вылавировали. А потом протокол про протокол протоколом запротоколировал, как интервьюером, и лигурийский регулировщик речисто да нечисто рапортовал, да не дорапортовал, дорапортовывал, да так за...
Okay. So, any idea what was it about? Anybody could understand?
Nothing.
See, this, nothing. So this is how your child is listening after the switch on immediately. When you have given the surgery and the switch on, the child can hear all the words, all the sounds, but the child cannot understand what he says. This is Russian language. Since we don't know Russian language, for us it's a jargon. It has no meaning. But for Russian people who know the language, they can understand it very well. This is the best example to make you look into the insight of in the auditory brain of the child. The child does not understand the language, and we expect the child should turn back when we call the name immediately after switch on, should understand. This has to be trained. The brain has to be trained. So auditory habilitation is a system which helps these children to become part of mainstream society. That is why AVT is essential. Let's go through some research findings to put my point up there. There is a concept of 46 million words, or there is another part which we call concept of 32 million words. I don't know if you are aware of, there is a CI surgeon working in Chicago in the General Hospital, and she has done many surgeries, and she has written a book which is 32 million words. If you get a chance to read that, you will be able to understand a surgeon's perspective that surgery is not enough, and what the surgeon can do to see that the child reaches integration truly and change the life of the child. This is all based on the research findings, which shows that a child hears more than 1200 words in 1 hour. So if you are telling a child that it's okay, you are too young, you can have surgery after 6 months, or the parents say we want to wait for 6 months, and you say that's fine, the child is very young. Imagine how many words the child is going behind. Will we be able to give those many lakhs of words to the child after the surgery? So early intervention is very important from this point of view. This is again based on research that what we need is when you're doing surgery, you are giving us access to the auditory brain, right? Now for us it is to develop that brain, to grow that brain. Because the child was not using the auditory brain, the brain has started shrinking and it's shrunk. Now we have to make it expand it and go back. So how do we do that? This is again on the research findings that a child who's 4 years old throughout the world goes to a regular school, and by that time the child has heard 46 million words. Now how many words our children have heard before they are sent to the school at the age of 4 years? They might not even have the implant at that age, so no full auditory access. So we have to access and stimulate the auditory brain centers after the surgery, and we call it brain library. I'm not taking you through, there are lots of videos to show on the neural connect. I don't have time for that, so I'm just taking you through it quickly. That neural structure has to be developed, and that is the role of an AV therapist. This is another research which was done recently, that a child, if he or she listens within first 6 months of life, then there is no need of therapy and there is no need of gap. The child will be at par with the other children. Now, how many of our children are going through surgery at 6 months? You all know. Listening and spoken language, communication and literacy, all this has to be developed, but this can only be developed through early auditory brain access. The auditory brain has to get used to it and has to imbibe this. Rapid auditory brain development can happen only if the brain is stimulated. How the brain is, auditory brain, how it is stimulated? By language, by listening. And then there should be more talking by the parents. AVT is working through parents. So what does it take to have the proper spoken language outcomes after surgery? What we need is, we have to engage a professional who is AV therapist. So what are the conditions? That the person should be highly qualified, and in what? In the development of listening and speaking stages, but not only theory, through parent coaching techniques. This is more important. The last line is more important. We can go through the net and read all about the hierarchy and developmental stages, but when we sit with the child, we don't know what to expect from the child. And if what we expect the child doesn't do, how do we change? That is techniques of parent coaching, because the child is with the parent all the time. So I am not teaching the child directly. I am teaching the parents how to teach the child. And for that I need to have a skill, and I have to have the insight and the knowledge that I have to grow the baby's brain. What ABT therapists should know, when we give this responsibility to an ABT therapist, they should know not only about the language and speech development and listening development, they should know about synaptic strengthening. The details of synaptic strengthening, what does it mean, how do we handle this, how do we manage, how do we develop, how do we help parents to work on that. Then another concept we have in AVT is brain library. We are literally building a brain library. So how do we build that brain library, what does it mean, and how do we develop this is all AVT. The AVT specialist must know theory of learning. Adults learn in a different way, the children learn in a different way, and babies have different way of learning. So as a therapist, if I'm dealing with a particular age group, I must know how do they learn so that I facilitate the learning. I don't believe we can teach everybody. We can make people learn. We can't teach. And if a person doesn't want to learn, you can't teach. So we have to facilitate learning. And this is a skill which is developed in the AV therapist. They should also know the executive functions of the brain. There are so many executive functions, and we have to develop them right from the first day after surgery or even before in pre-implant therapy. We have to know the role of attention, how to develop attention, how to make use of attention, how important is attention. AVT therapists also know about auditory memory, how to increase the span of auditory memory, what are the techniques of auditory learning. If the child is not listening because the child has never listened, is not used to it, what listening strategies I use? So the child learns to listen by default and develops a habit of listening. And of course, the concept of 46 million words. So what is the aim of auditory verbal therapy? I don't know how many of your children who come for therapy have gone through pre-operative therapy. You will see the difference. The children who have gone through pre-operative therapy and then go through surgery and continue therapy, they will go faster. Their outcomes will be better than the children who did not have any pre-operative therapy, and the therapy starts only after surgery. So please think about it. We have many surgeons who are very careful about it and tell the patients to go to a particular clinic, get admission, come back for surgery only after that. You all know about post-operative therapy, so I'm not going in details, but this will also develop the functional use of audition, not only the physical use of audition or how much loss is there. To encourage communication, we start AVT with babies who are 6 months old. And we are not working on language, but we are working on pre-verbal skills with them. In Mumbai, we have 6 months old babies who have got simultaneous bilateral implant, and they are going through surgery, therapy, but I don't think they will need more. What we need to do is help the parents. The parents need to know how to talk to the child, what to talk to the child, when to talk to the child, and why to talk to the child. And all these 4 questions have to be answered by the therapist to the parents to make them competent enough to develop the spoken language of these children. So post-operative therapy is also development of effective spoken language, and we have different stages of hierarchy of listening and language also. Factors that will affect the outcome, age at diagnosis and age at implantation. Age at implantation is most important factor for outcomes. I'm sure some of you have had the program and have realized that audiological management is very important. I know some of the children who are going to remote area and not coming for mapping also, so their outcomes are affected. Again, we have to be very, very conscious of the children's parents going through emotional trauma and how to handle that, how to help them to get out of the grief period. This is all what AVT therapists do. Most important is skills of the therapist. If the therapist is not trained, it is not experienced and does not have knowledge, it's directly affect the outcomes of the children, because parents are learning from the therapist and sometimes they leave it to therapy. I'm very surprised to see in some clinics where parents are sitting outside and therapy is going on. Then how will parents follow at home? What will be the reinforcement and follow up? Nothing. So you don't expect good outcomes. Thank you. If time permits, I will show you one very short clinic video of outcomes. What do we expect? If there is early intervention and the children have developed spoken language communication, so I will share this screen with you first. Give me a minute only, I'll do that. Okay. So you will let me know when you can see the screen, please. Okay, can you see this?
Yes.
Okay.
Arjun Anirudh Patel. I am 5.5 and this year June. My name is Arjun Anirudh Patel. I am 5.5 and this year June with you I'm going to turn 6 years old. My favorite animal is fishes and dogs. I have 2 dogs. Do you want to know their names? Say yes.
Yes.
Okay. If the chair is moving so much, it's a funny type of chair. Yeah.
It is called revolving chair.
Revolving chair.
Yeah.
Try to hold the table.
Yeah. Who all are there in your family?
The fishes. Yeah. All these fishes.
In your family, who all are there?
I have so many people. So many hundreds of people. I can't tell you so many people. Only we are family I can tell.
Okay. So that is called, 1 minute. That is called your immediate family.
Immediate family.
Okay.
That we call it we are family.
Okay.
Do you want to know anything else?
Which school do you go to?
We are at the Pai Poda High School.
And you will be going in which standard now? Or you have already gone, I think.
Now I'm in 1st standard. So next year I'm going to go to 2nd standard.
Okay.
Okay. So these are the outcomes we expect and we show it to the parents that the child should be able to do this. There are certain points which can get better outcomes, and those are that we should start early. Early intervention, early implantation, and therapy by a standardized therapy by a professional. And parents' involvement, this all can help and children can go to regular schools. Just for your information, I'm conducting workshops for surgeons on orientation of habilitation in Mumbai. So all of you are welcome if you want to attend. This is a 3 days program where we take them to the clinics also and show them the record and documentation and planning and how the therapy is done. So this all cannot be comprised in half an hour presentation, but I just wanted to make you conscious of what is beyond surgery. Why should you drive this full program? Because many of you will be starting your CI program under one roof in the hospital. So there you should be able to do that, and we are looking forward to your contribution to these children to just change their life. Thank you so much. I will take questions.
Thank you, Jaspal. That was a wonderful introduction to AVT. And one question that is being discussed now, should we do implants in 3 to 5 year of age group?
I will not say don't do implants. What I will say is 3 to 5 age group, still there can be better outcomes, provided, like I said, factors that affect the outcome. Provided they had pre-implant therapy, or they had been using hearing aids, or somebody had been talking to them. So the environment is very important. And also, please give realistic expectations to the parents. The parents should know what are the chances of the child going into a regular school and getting integrated. Now our government says that we don't have to fail any child. The child will automatically go to the next standard. But how much they have to work hard with the child to develop the language, they should be prepared for.
Correct. Any other questions anybody wants to ask? Thank you, Jaspal. Thank you so much for joining in and giving us a wonderful talk. And I'm sure some of the audience will join you in Mumbai.
Thank you, sir.
Thank you so much. Thank you.
Thank you, sir. Thank you. Thank you, all of you. Have a good conference.
So can we switch to the operation theatre? Yeah, Dr. Raidu. Connect to the OT, please.
Good evening. Switch on this mic.
Yeah, Dr. Raidu.
Are you getting my voice, sir?
Yeah, absolutely clear. We have been watching your steps for last half an hour.
Okay, sir. We have exposed the anterior based temporomandibular flap and also the malleus, incus. There is a small fibrous connection between the lenticular process and the suprastructure of stapes. And also there is a squamous epithelium in and around the sinus tympani.
Okay, Dr. Rohit, can you just show us the audiogram and the scan if possible? Or Dr. Raidu, you can just tell us what are the findings.
The findings are only the posterior superior quadrant of the membrane is retracted and draping over the IS joint.
Okay.
And going some medially.
Okay.
We have to explore that. The rest of the middle ear is normal. You can see directly, you can see this now.
Perfect.
The rest of the middle ear, everything absolutely normal. That's why I want to open the cortical mastoidectomy. I want to start the cortical drilling, bigger one. As usual, reverse drilling technique. See my phone. Somebody answer my phone. You take my photograph also. Who is? Okay. Take one photograph also while doing surgery. Lift, answer. बोल दो सर्जरी कर रहे बोल दो क्या बात है बिगर सेक्शन As usual, I am starting from the tip. I am teasing some of the muscle fibers from the mastoid tip.
Okay, and on CT the mastoid was hazy or mastoid was okay?
Mastoid is okay. See, this is intact. So now also you are getting the fluid movement in the middle ear. Means that is the mastoid is very much intact.
Correct.
Just I am going deep.
But you still want to do mastoidectomy?
Just we want to do the cortical mastoidectomy.
Correct.
Because of the retraction pocket, is a well aerated mastoid. Just I told you now, just I am hugging the canal wall, going blindly posterior superiorly, without having any problem, hugging the canal wall. See, this is the fovea mastoidea. Previously used to talk about this attack of triangle. This is the attack of triangle. Instead of that, I am going simply from the tip towards the antrum. It takes less than 2 to 3 minutes to reach the antrum. See the speed of the burr. This burr is the Medtronic's burr. Highest speed, highest cutting rate. Just I am hugging the canal wall, posterior canal wall. I have reached the mastoid antrum. See how fast. For visualization sake, I am opening like a triangle. This is the antrum already. We have to tilt the microscope towards cranially. You can see these are landmarks easily. This is the outer attic wall, posterior outer attic wall I am drilling here. There is no disease at all. Everything is clear. Much to do here. You can see the lateral semicircular canal and also the tegment mastoidea. Everything is absolutely normal. No need to delineate all the cells. These are physiologically functioning cells. The mainstay here is the main hurdle is the disease presence in the sinus tympani. For that I will go like cochlear implantation. I will open the posterior tympanotomy. I make the posterior tympanotomy. Because we know how to do this area, that's why I am going to see clear the disease from the sinus tympani. I have explained the 4 quadrants based on 3 eminence and 5 ridges. Here also we can find the cell leading into the mesotympanum, that is called the Herald cell. This is the Herald cell already present here. If you want, I can show the incus also. Small drill. This is inguinal buttress, small drill. Where to open, I don't know. Then you have to make the positioning always to enter into the mesotympanum. Usually you won't do this step. Routine mastoids is a very simple disease, very simple mastoid, small one, not only cutting only, not that much, smaller one, this but bigger than that. Yes, next step for that. This is the lateral wall of the posterior tympanotomy, that is called the scutum area, scutal bone. I am drilling the scutal bone to see the anatomy without touching the body of incus. This patient, we are not doing the cochlear implant. This is a normally hearing patient. We shouldn't damage the hearing levels by touching the ossicular chain. Without touching the body of incus, I am exploring everything. See, are you able to see the body of incus and small process of the incus? Now I am entering into the tympanic cavity. Give the smaller. This is the Haller cell, directly communicating to the mesotympanum. Based on this cell, we can enlarge. It has to go deep. Based on it, I am expanding the posterior tympanotomy in a triangular manner. I am using the powerful cutting burr here. Slowly. That is the mucosa. Here you can find the bleeding. Smaller section. You can see there is a caudal eminence, smaller one. This is the caudal eminence. Smaller one. इसमें small है. Diamond also. Diamond. Diamond दे दो. Carefully I am going to the posterior tympanotomy to explore the pyramid. This is the caudal crest cell running from the caudal eminence to the pyramidal eminence. I am removing this one. It was not locked properly. Small pick. Now I am finding the colistometer sac here. I am removing the cotton ball. Pick, straight pick.
So, Dr. Raidu, one
Yes.
question.
Okay, gel foam.
Hello.
Yes, sir.
Yeah, in this case, you are doing posterior tympanotomy.
Yes, sir.
And after cortical, we will reconstruct. But the original reason for negative pressure would still remain. So, do you feel again it will get retracted?
Because we are making all the possible obstructive areas clearing now, sir. Posterior tympanotomy and also this area.
Yeah, why I am asking is Dr. A.B.R. Desai and others used to say, even Vijayan for that matter, that if there is a retraction or a cholestotoma, canal wall down is a better way with obliteration of the cavity.
Cholestoma, there also so much debate is going on, sir. The
True.
open cavity or the closed cavity depends upon the patient's needs and also his education levels and also the follow-up. This all will play for the making the decision regarding the surgical technique. Gel foam, dry gel foam.
Correct.
You can see these are the colistomatous flakes present in the sinus tympani. Just I am separating from the stapedial pyramid area and also sinus tympani. You can see it's elevating easily. You can see dry gel foam. This is the IS joint. This is the stapedius tendon. I am clearing the mucosa and the squamous debris. Here you can find the bleeding is coming, adrenaline cotton ball or Sergi cell. Somehow I will drill some inferiorly also to get the visualization. I will remove some part of the bone here, caudofacial angle, then we will see how it was clear. Water. If needed, sometimes you can drill the entire pyramid also to get the proper view of the sinus tympani. In toto, I am removing the sac present in the sinus tympani. Cotton ball and pick. This side. I am putting the cotton ball through the canal from hypotympanum coming to the retrotympanum area. Just I am elevating the cholestomatus sac with the dissection with the cotton ball. It's always helpful without damaging. You can see we got the clearance of all the mucosa. This is a round window niche. Now is everything clear? Are you able to appreciate this one?
Yeah, beautifully done. I think.
This is the card. Sorry. I will show the pyramid. Slow. It clears the entire disease. We will check the pyramid. Straight pick. This is the pyramid where the chorda, this stapedius tendon will coming out. Is only mucosa. There is no squamous flakes in around. Now we can flush everything. We can close it down, keeping a small fibrous fascia draping around the long process of the incus. Now we come to the middle ear through the canal. Are you getting the clear picture?
Yeah, absolutely clear.
Yes.
And is there a gap between the incus and the stapes, or they are touching?
No, sir. There is a gap. Incus and the stapes.
Little bit of gap.
No gap, but there is a fibrous tissue. Fibrous bands are there. Sickle. For that, I don't destabilize that one. I will use the small fascia to drape over all these things. It will attaches everything. It causes strong fibrous tissue. Now you can see everything is intact and mobile also.
Would you like to keep a piece of cartilage in between the incus and the stapes? No.
No, sir.
Okay.
Just I will.
When you move the malleus, the whole assembly is moving.
Yes, sir. See, it's moving.
Yeah.
Even the head of the stapes also it's moving.
Correct.
For that, I will drape the small fascia all over it. I will close and put the graft. It completes the surgery.
Okay.
Flushing and also this one. What do you want? Crocodile. To remove the.
No.
We kept the flaps anteriorly by keeping these gauze pieces. I'm taking out these gauze pieces. You can see the flap and also the posterior perforation in that flap.
So this shows beautifully if you know posterior tympanotomy, then you can save the canal wall and you can do it canal wall up.
Yes, sir. And small fascia to drape all around, and also this is the graft taken by Dr. Rohit Mishra. He is very well taken, very big graft. From this I am taking a small part. I will drape later, and also I am using this, not this much graft required. Very good grafts. I will prepare the grafts and also
Dr. Rohit?
Flush.
Dr. Rohit Mishra is there?
Bigger cannula. Yes, sir, he is there, sir.
Yeah, Dr. Raidu has been very quick. Can we take another case?
Yes, we can do, sir. The case is there, we can do the another case also.
Rohit?
Another 10 minutes we will complete everything.
Can we take up the real cholesterol now?
We should take, sir.
Huh?
We should take.
Yes,
Take up. We have 2 lectures. In the meanwhile, we will finish the lectures. You start the case.
Okay.
We can have under local anesthesia. Shall I show the local anesthesia technique?
सर एक्चुअली पेशेंट कोई एनपीओ है नहीं, सबको बोल दिया था.
चेक करो.
Okay.
सबको बोल दिया सर, बोल रहे सबने खा लिया.
Gel form. Small section.
Rohit is not interested in taking up another case.
I am interested.
We can show the depositor.
Dr. Rohit is NPO, it seems.
There is enough anteriorly covered the graft. Okay. Just keep me the gel foam. Otherwise, give the gel foam to me. Give the gel foam. Yes. Antibiotic soaked gel foam is there. Give me the gel foam. Gel foam. You can soak in the Neosporin H ointment is there. H. Is there? Crocodile? Crocodile. Saline. I am hydrating the flap. I am keeping depositor. I have hydrated the flap and also make the incision to drape around the handle of the malleus. Underlay. I am going underlay. Small suction cannula. Suction cell. छोटा suction cannula दे दो ना. It's difficult to handle the wet graft, but I use it to hydrate everything. Folding the flap anteriorly to place the gel foam below the flap gel foam.
Dr. Raidu, do you prefer a dry graft or a wet graft?
Anything useful, but for the beginners, better to have the dry graft. They cannot adjust.
Correct.
That's why the beginners
But, but in your experience, the results of wet graft are better or is the same?
The same.
Same.
But I prefer sometimes a wet graft. Okay.
Okay.
Gel foam. Usually I will use the gel foam soaked in Neosporin H ointment here for the better control of the gel foam to placing all over areas. If you go the drops, we cannot manipulate the gel foam as you like. That's why Neosporin H ointment is always better to use. You place in anterior place. Next, immediately you can give. But prior we have to push anteriorly to the handle of the malleus, and also.
Boss, you are using Neosporin H ointment or drop?
Now it is not available here. I am using the drops only.
Otherwise, you are using.
Always I will use the Neosporin H ointment and also applied on the compressed gel foam, not this gel foam.
Neosporin H ointment soaked gel foam.
We will compress the gel foam and also make small pieces. We will apply the Neosporin H ointment. We can meticulously place all over the areas, hypotympanum, protympanum, epitympanum. Like this we have to place. Next. Fast. Neosporin H ointment. Yes, that's better. See, how can we handle with the ointment? Now they applied the ointment here. We will have the better control of the gel foam. We will have the better control. Put the ointment. I have been placing all around. Give me that. Now I will drape the handle of the long process of incus and the stapedial, incudostapedial joint with the fascia, small fascia. Crocodile. See here also, first I will measure. This is also very bigger one. I will make it shorter. Scissor. After this also I will measure again. Now we can beautifully drape all over ointment or the small eye. Now I am applying the ointment over the graft to soften the graft. You can see how I am draping.
Hello.
Are you able to?
Hello, Dr. Raidu.
Sir.
Please let us know what we are doing now. What is this gel foam or
now I am doing. I am keeping a small fascia draping all around the long process of the incus and onto the incudostapedial joint.
What is the advantage of this fascia?
Incus small lenticular process was little bit eroded. It has only fibrous band. That's why I am doing this. Saline.
Will this not hinder the ventilation of the mastoid?
No, just
the posterior isthmus.
I am draping all around. See, I will how we will drape over that one. Just like attaching to the long process of incus without having any space occupation. Just see how I was draped here. It was long process of incus and all over the joint. Dry gel foam. You can see I have already draped everything, and also I will keep a small dry gel foam. Small dry gel foam in between the small gel foam. Okay. And also medial to the long process of incus. Small gel foam. There is enough space. Are you able to appreciate this one? This is the stapedius tendon, IS joint. I have draped all over the incus. Small dry gel foam. Smaller one. This is also big. I will compress it. I will push medial to the long process of the incus to hold that draped fascia. Are you able to appreciate this fascia? Sir, are you able to appreciate this fascia or not?
Yeah, fascia is appreciable.
Yes, okay. Where is the obliterating the space? It's only draped around the incus and also the out to the joint. It gives the better mobility. You can see the movement. Okay, now I will.
Picture is little blurred. Please focus. The middle ear side. It's little better now.
Okay.
No, again got worse.
Okay.
Little better. Yeah. Now. Now stop.
Okay.
Yeah. Okay.
Okay. See how I have draped all around the IS joint and also the long process of incus. Now ointment. Now we will complete the rest of the placing the rest of the gel foam, ointment gel foam.
Will you use, where will you use ointment?
Ointment for the gel foam.
This is ointment soaked gel foam.
Ointment soaked gel foam for all over the middle ear cavity and the mastoid.
What is the advantage of ointment over the drop?
Ointment, we can manipulate the gel foam as you like. It will be hard, then only you can manipulate easily. If you use the antibiotic drops, it's very soft and we cannot manipulate easily to place here and there.
But we can use the dry?
Dry one sometimes it's difficult, sir. And also we can apply. Here also I am keeping, see, without much difficulty I can keep it here.
Will this ointment will not do the foreign body reaction in the middle ear?
No, sir. This is already H ointment. Use it for ophthalmic preparations. H ointment, I will replace this one, the graft. Again I have to place all over area meticulously.
Beautifully done, Dr. Raidu.
Not yet completed, sir. Just I will take the draping over the malleus. This one, crocodile. Crocodile. And also here I have to keep some gel foam to come contact with that. I made an incision over the graft to drape over that malleus handle. Now I am keeping the tympanic membrane. I am replacing the tympanic membrane over the neotympanum. It's clear. This is anterior margin. This is the neotympanic membrane where we have placed it through the perforation over the canal wall. We have elevated the corners flaps there, gel foam, bigger ones. I will pack this cavity with the gel foam. Are you operating another case? Not here. And also here I will use some dry gel foams to hold the edges of the perforation with the tympanic membrane. Small dry gel foams.
Dr. Raidu,
sir,
the audience is mesmerized by you. They don't want you to go tomorrow morning.
Sir, no.
So you skip your Ayodhya trip and stay with us tomorrow morning.
I have to get permission from the home department, sir.
So we'll celebrate your wife's birthday day after tomorrow here.
Total family members are waiting at Tirumala. They have already reached there with the special recommendations from CMO office. Usually this is a very rush time.
No, wonderfully done. And now, Dr. Raidu, we are starting the lectures.
Okay, sir.
Thank you so much. Thank you.
Thank you.
Great round of applause for you.
Thank you.
Wonderfully done.
Thank you, sir.
Excellent.
Feel the.
Thank you so much, Dr. Raidu, sir.
Thank you, Amma.
It gives me It gives me great pleasure to now invite our esteemed faculty member, Dr. Ashish Chandra Agrawal sir, to the stage to deliver his talk on types of mastoid surgery. Please give a huge round of applause for sir. As moderators, we have
moderator to invite Dr. Pankaj Srivastava sir, Dr. Chitransi sir, and Dr. Sushil Kashyap sir. Please have a seat.
Good evening, one and all. I'll be giving a lecture on mastoidectomy. This is one topic which most of you are well versed with, and those who are not during the yesterday's temporal bone dissection and whatever procedures would have been done today, I'm pretty sure that most of you would have got a very good idea about the various types of mastoidectomy and what issues you can come across while doing the procedure. I will very quickly outline the procedure, discussing the relevant surgical anatomy, the various types of the surgery, indications of mastoidectomy and the complications of mastoidectomy. So the temporal bone consists of 4 components: the squamous, mastoid, petrous and the tympanic part. One important aspect in the anatomy is the McEwen's triangle, which is bounded superiorly by the temporal line, anteriorly by the posterior superior ear canal wall, and posteriorly by a tangent drawn from the midpoint of the posterior wall of the ear canal. And the mastoid antrum lies around 1.5 centimeter deep to this surface. Now, few important terms, something which is called as an anterior buttress. Now, it's the point at which the anterior bony canal wall meets the tegment tympani. Then you have the posterior buttress, which is the point at which the posterior canal wall meets the floor of the external auditory canal. And this posterior buttress lies lateral to the facial nerve, the vertical segment. And if you remove the posterior buttress, the floor of the ear canal slopes gently into the mastoid tip. Now, this aspect is of importance because if we are doing a canal wall down mastoidectomy, we should lower this area adequately so that the mastoid cavity communicates with the middle ear cavity. Then something which is called as a facial bridge. Now, it's the portion of the posterior superior bony meatal wall that bridges over and lies lateral to the ossicles. So, this is a line diagram in which you can see that the yellow, the area which is marked in yellow is the facial bridge. Then there is another entity called as the facial ridge. The green arrow in this diagram is the facial ridge, which is part of the posterior bony meatal wall. And deep to this, it houses the second genu and the vertical segment of the facial nerve. The facial recess, in the previous surgery, Dr. Raidu gave a very good, excellent demonstration about the facial recess, which is a space bounded laterally by the cauda tympani nerve, medially by the facial nerve, and superiorly by the fossa incudis. Now, a word about approaches and routes. Now, these terms are used interchangeably by most of us. Decent explanation about the correct use of these terms I could come across was in a textbook by middle ear, manual of middle ear surgery by Mehrotra, which says that by the word approach, it is meant that the method of access to the middle ear with respect to the soft tissues, like whether we are placing an endoral incision or a retroauricular incision. And by the word route, it is meant that the method of access to the middle ear with respect to the bone work, whether it's a transcortical route, also called as an outside in technique of doing a mastoidectomy, or a transmeatal or a transcanal route, which is an inside out technique of doing a mastoidectomy. Now, if we are taking an end oral approach, a transmeatal or a transcanal route is a bit simple, and if we are taking a retroauricular approach, then the transcortical approach, the transcortical route is a bit simple. But now this simplicity and complexity are relative terms. As we progress in our professional work, most of us become well versed with either of the approaches and either of the routes. Broadly, mastoidectomy can be classified as an open or a canal wall down mastoidectomy and a closed or a canal wall up mastoidectomy. The various procedures which come under the heading of canal wall up mastoidectomy includes cortical mastoidectomy, the posterior epitympanotomy, the posterior tympanotomy, and canal wall down includes atticotomy, atticoantrotomy, Bondi's procedures, modified radical mastoidectomy, and a radical mastoidectomy. Canal wall up mastoidectomy, the first surgery which we get to do on a temporal bone, is the canal wall up mastoidectomy of the cortical type. Now, this is also called as a simple mastoidectomy or a Short's mastoidectomy. Most of us, we open the mastoid antrum, we drill some bone inferior to the mastoid antrum, some bone posterior to the antrum, some bone anterior to the antrum. And the final picture which we come across is this, but ideally the bone right from the level of the tegmen to the mastoid tip, from all the accessible ASL posteriorly till the posterior canal wall anteriorly and till the root of the zygoma should be drilled for it to be termed as a complete cortical mastoidectomy. Now, the posterior epitympanotomy, so as I discussed in the previous slide, posterior epitympanotomy becomes a part of the complete mastoidectomy if we drill all the way towards the root of the zygoma. Then we have the posterior tympanotomy, which we saw during the previous surgery. So, in all these three categories of surgery, we preserve the posterior and the superior canal wall. Now, there could be a combination of a cortical mastoidectomy and an atticotomy, opening of the attic done by a transmeatal route. Now, this does not constitute exactly into a canal wall up technique, it is somewhere in between. Then what are the indications of canal wall up techniques? One is mastoiditis or mastoid abscess, coalescent mastoiditis, masked mastoiditis. Many surgeons do it in the mucosal type of CSOM, which is refractory to antibiotics. Now, this again is a debatable topic. Some people, many surgeons are for it, many surgeons are against it, but there is no harm in doing a cortical mastoidectomy in cases of mucosal type of CSOM. It is an approach to various surgeries. It is the initial stage of any transmastoid surgery, whether it's an endolymphatic sac surgery or a facial nerve decompression, translabyrinthine approaches to the cerebropontine angle, approaches to the preterus apex, or cochlear implant surgery. Next, we have the different types of canal wall down procedures. Now, I have put three photographs. In the first photograph marked as A, the surgery has been done through the ear canal by the canal route, and the lateral attic wall has been drilled, leaving behind a thin shell of bone which we call as the facial bridge. In the next surgery, the same surgery has been done, but the facial bridge has been removed, and in pictures marked labeled as C and D, same technique has been done, but only the anterior part of the facial bridge has been removed. So, it is a partial removal of the facial bridge. Now, this technique requires a little bit of skill. This is one criteria. Then the disease should be limited to the epitympanum. It should lie preferably lateral to the ossicles. it helps in preserving the hearing status of the individual, and patient should be willing to come on a regular follow-up, and they should be willing to get a second stage surgery done if required. If we extend the inside technique of atticotomy little posteriorly, it becomes an atticoantrotomy. Means if the disease is not only confined to the epitympanum, it extends through the additors towards the antrum. This is one of the technique which we can do. And then we have a Bondi's operation, which is similar to an atticoantrotomy, but the tympanic cavity is not entered. If we try to understand this diagram, this is the cholesteatoma sac, and inferiorly we have the tympanic cavity with an untouched ossicle and the tympanic membrane. The lateral wall of the sac has been incised. Whatever keratin debris is there within the sac is sucked out. The entire thing is marsupialized, and the surgical site is closed, and the patient is advised to be on regular follow-up. Now, one of the very frequently done surgery is a modified radical mastectomy, or any further extension of it, which is called as a radical mastectomy. In a modified radical mastectomy, the aim is to combine the middle ear, the mastoid cavity, into a single smooth walled cavity draining through the ear canal, while preserving the middle ear mucosa. Remnants of the tympanic membrane on ossicles, wherever possible, are preserved for the purpose of hearing reconstruction. So, in this diagram, this is the left side ear, this is the middle ear cavity, this is the epitympanum, and then the mastoid. The facial bridge, the facial bridge has been removed, facial ridge has been lowered, and the entire thing becomes one single cavity exteriorized to the ear canal. The indications of MRM include an unreconstructible posterior ear canal wall, unreconstructible either because of destruction by the disease process or by an accidental injury to the ear canal while doing the surgery. And if the surgeon is not well versed with reconstruction techniques, they might as well reduce the posterior canal wall completely. Then if there is a failure of a canal wall up procedure, the patient is, we as a surgeon, we gauge that the patient might not come for regular follow-up, then it is better to do a canal wall down or a modified radical mastectomy, or those who have a poor eustachian tube function are also candidates of this procedure. An extension of this mastoid MRM is a radical mastectomy, which is done to eradicate middle ear and mastoid disease, in which the mastoid cavity, tympanum, and the ear canal are converted into a common cavity excised to the ear canal. This surgery is similar to an MRM. The difference is remnants of the tympanic membrane, the middle ear mucosa, and ossicles, except for the foot plate, are also removed. There is no hearing reconstruction, and the eustachian tube is occluded. The indication of this technique in today's era are quite limited. If the cholesteatoma is extending down into the eustachian tube or towards the petrous apex, we might consider doing this procedure, or in cases of temporal bone malignancies, these procedures can be considered. The advantages which we get by doing a canal wall up mastectomy are the tympanic membrane is more in a physiological position. The hearing reconstruction results are better. The mastoid cavity issues are not there. Patient will not have a persistently discharging cavity. Once it heals, once the entire canal wall up wound heals, rarely after a certain period of time, they start behaving like any other normal ear. And hearing aids are easier to fit, and hearing aids give a better outcome. The limitations are, as compared to a canal wall down, it's a little technically difficult technique, but again this difficulty is subjective. As we mature as a surgeon, we become well versed with either of these procedures, and chances of leaving behind a residual disease are there in a canal wall up procedure. The advantages of a canal wall down include that chances of residual cholesteatoma are low, and it is easy to inspect the cavity on follow-up visits. The limitations are mastoid cavity issues, they will keep discharging, patients are advised lifelong follow-up. Hearing aids are difficult to fit, they might give less than adequate outcomes, and if the position of the pilla might be altered on a long-term basis if these suturing techniques are not followed properly. The complications of mastoidectomy include worsening of hearing loss. Again, if we are careful, then we might not worsen it if we not improve it. Vestibular symptoms might be there. Accidentally, we might drill on the semicircular canals of the vestibule. Blood loss. Blood loss could be due to injury to the sigmoid sinus, to the jugular bulb. Catastrophic complication like injury to the carotid artery might cause a significant amount of blood loss. Wound infection is a non-specific complication. It can happen with any surgery, even with this surgery. If proper asepsis techniques are not followed, then there could be chances of CSF leak and its sequelae like meningitis, which again is a fairly preventable entity if we have a good idea about the anatomy. Facial nerve injury, a dreaded complication for any otologist. Again, it's a preventable thing. And then cavity problems. Now, all these complications happen during the initial stage of our surgical years when we are not well versed with the various techniques, with the relevant anatomy. And I would like to emphasize that good number of temporal bone dissections are important before embarking on any mastoid surgery on a patient. With this, I finish this talk. I thank the audience for their patient listening and the organizers of this event, Dr. Rohit Mehrotra and Dr. Praveen, for giving me this opportunity to speak in front of you all. Thank you.
Very good talk. But little bit about how to avoid the complications, especially if you are doing the canal wall up surgeries and canal wall down surgeries. In canal wall down surgery and how to identify the ossicle in case of the granulation. These are two things.
In canal wall down surgery, how to identify ossicle?
How to identify ossicle if the middle ear is filled with the granulation?
What I do in such patients, I give pre-operatively good duration of antibiotics, both systemic as well as topical, like levofloxacin, ciprofloxacin, or culture-directed antibiotics like cephalosporins and coamoxiclav, and topical antibiotic with steroid preparations like clotrimazole and ciprofloxacin ear drops. So this reduces the intraocular inflammation. Then in a canal wall down mastoidectomy, initially I do a cortical mastoidectomy first. My tympanomeatrial flap would have been raised. I get a fairly decent idea about the status of the ossicles. If the incudus tibital joint is intact, I disarticulate that joint. I remove the incus after this. I decapitate the head of the malleus. And then I start lowering the superior and the posterior ear canal wall. So with this sequence, I have found that in most of the surgeries which I have done, the outcomes have been fairly decent.
Okay. Any other question? Thank you.
Okay, thank you so much.
Thank you, sir. I would now like to call Dr. Praveen sir and to felicitate Dr. Ashish Agarwal sir. Thank you, moderators. Now we have a lecture by our esteemed faculty, Dr. Pankaj Srivastav, sir. I would like to call sir for the lecture. I would like to call on stage Dr. Chitranshi sir and Dr. A.K. Srivastav sir as moderators, and Dr. Rohit Mehrotra sir as moderator.
कहाँ से होगा चेंज अच्छा वो नहीं दे दो चलो ठीक है नो प्रॉब्लम
Dr. Pankaj Srivastav is a senior ENT surgeon from Lucknow, and he is my batchmate. We have done MS from KG together. Prolific surgeon, and thank you, Pankaj, for coming in. Go ahead with your talk.
Thank you, Dr. Rohit. Thank you, Kanpur, for calling me. So I'll be discussing the topic which we all do daily. So there are some tips and things to be noted. What I practice in my hospital. So in CSOM we are all clear. All chronic perforations has to be operated unless there is any surgical contraindication. But in children we usually wait for some time for child to grow because there is some problem in children. Not doing surgery. Surgery doing is not a problem, but children are sometimes catarrhal. Child is profuse discharge is there. Adenoid problems are there. They are allergic. Post-op care becomes very difficult. Emotional factor is there. Sometimes if the surgery fails or there is a discharge or pain, the parents are very panicky. The surgery has been done. Why is there no response? So we wait in children for some time. There is a rare possibility of CSOM healing in children, which in adult it is not there. So in children we wait for some time, if possible, if there is no problem, but there is a risk of permanent hearing loss. But in adult, as soon as the patient is ready and there is no contraindication, we go ahead with the surgery. When to operate? In patients of CSOM, if we get time, we give some good amount of antibiotic for 10-14 days. That is all. Decongestants, ear drops. That is all the preparation is. If the patient has got any nasal problem, septum or something like this, there is no contraindication, we go ahead with the surgery. If there is a specific adenoid problem, a specific nasopharyngeal problem, we have to address before ear surgery. That is all. In children, definitely we have to see allergic child, adenoid hypertrophy. This has to be taken care of. DNS, never. When we admit the patient, this is very important because usually patient has got bilateral hearing loss. So we have to be very specific, very clear, recording that whether we are going to operate right or left. That is the problem sometimes happen. Because sometimes 6 months back, 2 years back, you have talked to the patient and decided for right ear and now you have planned for left ear. So we, in the case sheet, in patient's handwriting, we record what is the problem and what it is going to be done and what do you expect. These are the 3 things which is very important in patient's handwriting. That solves your medico-legal problem. Second thing is patient has got what is the primary problem? Tinnitus, hearing impairment, discharge or simple perforation. So if the patient has got specifically, he has come for tinnitus, definitely you have to take consent for that. So you and patient both are very clear what you are going to do and what patient is going to get. Anesthesia, we all know we can do with local anesthesia. If I do in local anesthesia, I do give dexmedetomidine. That is a very good sedative, very good hypotensive and very good bradycardia creator. So that is a cooperative sedation. If we give 14-phenargan, midazolam, that is an uncooperative sedation. So that is the thing. If the patient is not cooperative, definitely anesthetist is there. Whatever he decides, we have to go with the anesthetist. This is very important, the preparation. Now the patient should be comfortable, the surgeon should be comfortable. In patient has to lie down with not overextended, tilted neck, because you have to do it for half an hour, 1 hour, 1.5 hours. Patient should be comfortable if he is in local anesthesia, and more important is surgeon should be comfortable. So your stool should be very good, branded with a backrest. You have to sit on the back of the stool, not the anterior edge of the stool, so that your back does not create problem. You don't have to lean down. So adjust the microscope, the height of the patient table, so that you are straight. Adjust, take advantage of the eyepiece. If you have got a tilted eyepiece, take advantage of that and then fix the microscope. Patient should be on your side, your edge of the operating table. So your hand should not be extended or hanging up. So this is how you prepare the patient. Your trolley should be covered with the polythene sheet. So there should be no linen which creates a microfiber which goes inside the patient's middle ear. That is important. And 15-degree head up is important, so there is no venous congestion and your bleeding is reduced. I take incision which is exactly at the crease of the pinna. So skin at the crease and skin 5 millimeter behind the crease behaves differently. So in the crease there is no hypertrophy, there is no visibility, no means no visibility, and there is no chance of keloid formation. 5 millimeter behind that, there is all possibility of everything. Always mark pointer. Always mark the skin before the skin incision, because sometimes there is an up and down. Always take a mark with the blade, because sometimes we see that in post-op time the pinna height is different, so that is incorrectable. Take care of that. Incision. Take incision along the pinna cartilage, and anterior tissue should not be left, so that your retractor, when it is fixed, you are centered to the canal. If you leave a lot of tissue anteriorly, the center of the retractors will be posterior, and it will be difficult to see the middle ear. And skin is, the incision is very small, just to open the mastoid. Mastoidectomy. I always do mastoidectomy because it is important. If you leave any disease in the mastoid, that will create problem in healing, or the failure is there. So in 6% of my cases, I get disease in the mastoid, or the water entry or the water test is negative. So mastoidectomy, it's all have discussed. So these are the cases when we get tissues in the mastoid. It's a granulation tissue or something which is obscuring the entry to the middle ear, and the adductus is blocked. Definitely this will fail the tympanoplasty. Now what graft? I always take fascia. That is the best graft, nothing else. And fascia, it may be from the same ear, if it is a revision from the other ear, or from the fascia lata. I think others facial graft like perichondrium or cartilage, everybody is doing that there is no problem, but I find it is the best one. Fascia harvesting, it should be large enough, because I keep large fascia, so it's the largest possible fascia harvesting, and if we can keep this fascia in the chilled saline, because we take a wet graft and want to keep it live, or we can harvest partially and keep it in situ, or take when the grafting is to be done, immediately before the grafting has to be done. So I always take a wet fascia, and the results are very good. Canal incision. It has to be, the skin is our friend, and if we lose the skin all around the canal, the graft uptake will be in danger. So we have to cut the skin posteriorly, just at the level of the mastoid bone. if we go downwards, sometimes the inner skin is very weak or granulations or myringitis is there, so the skin loss will be there, then graft draping will be compromised. So skin incision has to be at this level. Sometimes there is a problem of thick skin. So just trim the skin at this level and keep the soft tissue here. And if the visibility is not there, we can just do some canalplasty. So by taking skin incision superiorly, we have a good amount of skin which is going to drape the graft. This is how we take the incision. This is posteriorly, this is already a posterior entry into the canal. Then there is a vertical incision at 7 o'clock position. Then complete circle till the, so it is a 360-degree canal incision, but in 3-dimensionally, there is a good amount of vascularity which is available. So if we have a good exposure of the middle ear, we can play with the middle ear, we can keep a good graft there. So a skin incision is like this. Now, this is very important. When we see a perforation, people are doing just freshening the margin. This is not important. You have to see the membrane as a whole. If the membrane is parchment-like, tympanosclerosed, vascularity is not there, leaving this membrane is in more danger. So see the membrane. If there is a myringitis, granulation, thin membrane, we have to remove all the membrane, whatever it is possible, even the skin, canal wall skin. So go up to the margin where there is a good margin and good vascularity. Don't see the size of the perforation. Even the pinhead perforation for me or a subtotal perforation, it's the same disease. So don't go by the size of the perforation. Go by the health of the tympanic membrane or the skin canal. So suppose this is like this. It's a simple thing. Everybody is doing that. Now, one thing about myringitis. If there is a myringitis, it is like cholesteatoma. You have to remove all the membrane, all the annulus, drill out the bony canal wall because it reverts back. What is the disease? We don't understand. Myringitis reverts back. So remove everything which is possible. So this is the posterior incision, there is a vertical incision, and this is anterior incision. So all 360-degree we have to elevate till the annulus. Then I do interlay fascia grafting. So we have to remove the epithelium, leaving the annulus all around. So there is a good amount of bed available on the middle ear of endothelium. This has got a physical support, vascularity, so the graft will be live early and results will improve. So interlay fascia grafting. I'm skipping the video. Now one thing is important, there should be no skin loss. Edge to edge we have to secure the skin so that when it is reflected back, there is edge to edge approximation of the skin. If there is a gap sometimes, when we drill out, sometimes do canalplasty or anything, so we have to cover that bone with the fascia or the skin. No bone should be left bare. Ossiculoplasty, we do cartilage preserved ossiculoplasty, not discussing in detail, but the results of ossiculoplasty is not so good as we expected for grafting or a mastoidectomy or a dry ear. So that's a different topic, not discussing. So we preserve the cartilage, many of us are doing that, and the 70% alcohol, and use accordingly what is available, what ossicles are available, and do direct steppies to graft or whatever it is. Now graft placement, that is very important. You do everything, and if the graft placement is wrong, everything is going to fail. So we have elevated all 360-degree skin and just drape it superiorly and pull it laterally. So that is how we can expose middle ear full in front of us. Only the malleus is seeing. Then I take a wet graft with a tongue shape. 5 millimeter has to be at canal, bony canal anteriorly, then full medullary, then whatever it is available, posterior wall is covered so that any bone is not left raw. It goes under the malleus, very important, and already the malleus has got the skin so that there is dripping. Inside there is endothelium, superior laterally there is a skin, malleus and canal skin. So there is a very good fixing. So we can see the whole medullary is available, the skin, all skin is here. Everything is exposed, malleus is visible. Length is more, but width is not. That is malleus, it has to go under the malleus. Oh. No problem. Now, we want the skin, the graft and the annulus or the endothelium has to be in close approximation. When we keep the graft and put the gel foam, there is always some secretion or bleeding is there, and if it goes between these layers, definitely there will be a failure. So we want a good amount of pressure on that. So I keep a gel foam lining and then keep a good size cotton ball which is squeezed between the gel foam so that there is a close approximation, and this cotton ball is removed after 2 weeks. And then keeping the gel foam, it should be half at the skin, half at the membrane. If we put in the membrane, that goes inside the skin and separation is there. Then create a well of the gel foam, and this cotton is squeezed inside, seeing all the margin of the skin so that you don't push everything inside. The skin margin should be seen. This gives a good pressure, and the pressure from inside middle ear, that is not harmful if it is collected. So that is very important. That improves the result. Closer, that is normally closer done after this cotton wall packing. We put gel foam, then a small sulfamycin pack without a push. 2-layer closer is done with a drain. Drain is important because there is always collection, serum collection or blood collection post-operatively. If it collects inside the middle ear or mastoid, that can push this can push the graft, or that can be a cause of failure. The size of the incision is small. With the drain has to be removed after 7 days. Dressing, drain and stitch removal after 7 days. Cotton canal cotton is to be removed after 14 days. And once, twice or thrice monthly follow-up is there. What can be the problem? We know there can be a failure. If we see that the patient is having discharge after 2 weeks or 3 weeks, examine the middle ear cavity, and if your graft or cartilage or whatever you have kept, it is sloughing, don't wait. There is no chance for giving antibiotics or culture or anything. Remove any sloughing tissue immediately. That will reduce your size of healing. And wait for say 6 months to 1 year before revision, because sometimes even after removing the graft or something, it may heal because you have done everything. You have removed the disease, you have freshened the margin. Wait for the response. Pain, if it is there, normally never happens, but if periconditis is there, there can be pain. You have to treat as external otitis. Facial weakness, if it happens immediately, you have to revisit your recording. Or if it is having 7-10 days, definitely deal it with the like a Bell's palsy. It always improves. Revision, wait for it. Better somebody else does the revision, or call someone with you if you are revising. Consider tuberculosis if there is extraordinary pain, facial paresis in central perforation, or if there is a discharge or disproportionate hearing loss. If all four are there, I always send anything which is removed like mastoid tissue, tympanic membrane for biopsy. If it is suggesting, start ATT. Thank you.
Beautiful lecture, and I think juniors, you should ask some questions from him, not me. Hello, wake up. He will explain to you each and everything what you would like to ask. Please, yes, take a mic.
Oral antibiotic I give for 7 days, then dressing removal, then extend for next 5 days. So this is all 12 days. Ear drops start after 7 days, and already the gel form which we are putting, it is in ciprofloxacin. Infection is never a problem in ENT. This is my opinion. It's not a primary problem. The primary problem is sloughing. If you have kept a thing which is sloughing, infection will be there. Remove that, infection will go.
Usually it's not easy to carry on the operation due to post.
No, I didn't say. Ear is as good as adult ear, but the post-op follow-up or the diseases or the catarrhal child or nasopharyngeal nasal problem, they can cause failure.
Family person also not willing usually.
Yes.
Then sir, I just want to ask up to how long we can delay the operation and what are the conditions we can wait it may get healed.
You may have to take a balance. There is definitely a problem of permanent hearing loss, ossicle disruption, and we know we are not 100% sure that we can do whenever we do surgery, the hearing will return. So there is a risk, and there is a risk of failure, and there is a risk. So you have to make a balance. If parents are ready, child is so that it is not catarrhal child or adenoid or these problems are not there. We immunize the patient, influenza vaccination, pneumococcal vaccination. After 1 month, he can go ahead, no problem. Patient should be realistic. Parent should be realistic, that is all. Post-op care is not, even if you want to suck the child, examine the child, he is not cooperating, so that becomes the problem. Doing surgery is absolutely equal to adult, there is no problem.
You have to see either the flakes are coming out or there is a gross retraction of the tympanic membrane and medicines are not going to help, then you have to consider a surgical option.
Sir?
No. As I told you, if flakes are there, it means there might be a hidden cholesteatoma there. And if the gross retraction is there, and it is not going to cover, then you have to consider a surgical option, because middle ear is very important, and if you are seeing that middle ear is not there, then you have to do something for the child.
Sir, in some cases, at the time of graft placement, we are struggle with bleeding problem. Now, how can I avoid bleeding at the time of graft placement?
Yes, you have to distribute your surgical steps. Everything, whatever you do in the middle ear, like elevating the skin flap, removing the granulation, whatever you want, do it there, and then take graft, or you can do mastoidectomy later on. If there is a problem of bleeding is still there, keep adrenaline cotton and ask the anesthetist to reduce the blood pressure. 80 systolic if you get, you will be able to do that, no problem. But in bleeding middle ear, you should not do. The results will be compromised. Thank you.
Pankaj, hello. Pankaj, this mastectomy is a elective surgery.
Yes.
So some surgeon prefers to perform surgery in a dry ear, but some say there is no difference between dry and wet ear. What is your opinion?
I do surgery whenever the patient is ready. There is no difference between discharging ear or a dry ear. That is true. It has to be, but the skin should be healthy. If there is external otitis or skin is sodden, definitely that is not the time to do. If patient is prepared, discharging it is no problem. Because problem is not the infection. Problem is inside. You have to correct it, and this will be the things will be corrected.
So sometimes you find that in spite of all good antibiotics, patient is not getting a dry ear. What do you do?
Sure.
You have to operate.
It happens.
There is something which is creating problems.
Which is surgically or structurally there. You have to correct it.
Any other questions? Thank you very much.
Thank you, sir. Thank you.
Please wait, sir. Now I would like to call Dr. Praveen Saxena, sir, to felicitate Dr.